All right. Good morning, everyone. This is the December hearing of the Joint Audit and Valuation Committee. We're pleased to be here with many of our members from the House and Senate. We have a very busy agenda, and we have folks from the Office of Legislative Audits. There are two main things that are being discussed today: Department of Public Safety and Correctional Services, as well as Maryland Department of Health. Probably, in my opinion, some of the most troubling audits that we've seen in recent history. And so we have a lot to discuss today. Let me see if my House colleague, Chair Solomon, has anything else to add before we get started.
The only thing I would say is I know we've got a really full agenda. It's December. I know we've all got a lot on our plates, so let's try to keep our questions streamlined and to the point so we can get out of here in a reasonable amount of time. But thank you, everybody, for being here.
With that, first on the agenda is the incarcerated individual healthcare contracts, Department of Public Safety, Correctional Services, and MCE, as well as Central Operations. We'll begin with our Office of Legislative Audits and Mr. Brian Tannen and his team.
Good morning again. For the record, Brian Tannen, your legislative auditor. With me on my left is Josh Adler, one of our audit directors. On my right is Eddie Rubenstein, another one of our audit directors, Rob Smith, one of our audit managers. I'd be remiss if I didn't acknowledge Chris Mattis, who's behind us, who will be presenting later, and two members of this team that were responsible for this healthcare report. I'd ask them to stand. Tony Calcagno and Thea Cimento, they're both back there. They were integral in getting this report to you today. At the last hearing, I was quoted as saying, "This is the first time I had seen something like this in my 29-year career." I wish I could say the same thing about the report we're going to testify today. And if I may, I told my team there's always a concern that their presentation will overlap with mine. I said, not a concern. I'm not going to be reading anything from your report. DPSES had not established processes to pursue liquidated damages for contractor noncompliance, high staffing vacancy rates in some service delivery areas. That's from a special report that we issued in 2017. Staffing levels reported by the medical contractor should be periodically verified to supporting documentation. Contractor compliance with scheduled work should be monitored. Appropriate staffing levels to provide all required services need to be determined. I could continue. That's from the 2007 report. So we're a little bit early with this presentation, 2007, 2017, and now we're here repeating those same findings. And I think the long history of problems with these contracts that we have identified, in addition, those were two special reports just on this topic. We've also addressed them in a number of fiscal compliance audits during that period. But on top of that, there are well-known concerns with ongoing healthcare contracts, both within Maryland and nationally. In the auditing world, there is a strong correlation between risk and the amount of controls that we recommend get put in place. When you look at these contractors and the poor performance that we've had on these contractors in the past, it demands a higher level of controls to make sure that the outcomes are different. And that's what makes this report so troubling. Despite the long history of failed contracts to provide these services, we did not see any evidence that those past failures were considered in developing these contracts. And that's why there is a first in this report. We recommended that and we addressed the fact that they didn't have a contingency plan. And quite honestly, I don't know if that's really a good word. A contingency means there's almost a 50-50 chance, or just in case. Given the past history, I think we knew that this was not going to succeed, and there was a need for there to be some planning in the event that it didn't, because we're not just dealing with numbers here. And our last presentations have all been focused on dollars and cents and less funds to the state. This one has a direct correlation to the health and well-being of a certain population that the state is responsible for. And with that, I'll turn it over to Eddie Rubenstein and Rob Smith, who will be presenting the healthcare findings, and Josh will wrap it up with the findings on the other two reports.
Thank you, Brian. Good morning, members of the committee. My name is Eddie Rubenstein, and I'm a Director of Compliance and Performance Audits at OLA. If we could go to slide 2, please, which provides a summary of recent audits that we've done of the department. As Brian said, today's presentation is going to focus on the healthcare contracts audit and certain findings from the central operations and correctional enterprises reports. Slide 3 gives an overview of the 3 contracts we reviewed for the healthcare contracts audit. Specifically, our audit focused on the procurement and monitoring of the medical, mental health, and pharmaceutical contracts that started between 2018 and 2020 that collectively accounted for over $1 billion in payments as of June 2024. As Brian said, our audit reports dating back to February 2007 have identified issues with these contracts. Slide 4 lists the key findings from our report, which I'll explain in more detail, starting with finding 1 on slide 5. We found that DPSCS did not structure the medical and mental health contracts to ensure it obtained adequate health care services and could not justify that the payment structure was the most advantageous to the state. DPSCS paid the contractors a fixed fee to cover the cost of staffing, medical supplies, certain inpatient hospital visits, and the contractor's overhead and profit. Given that the fixed fee model guaranteed the contractor's payment regardless of the level of staffing they provided and their actual cost incurred, this model may not have been in the state's best interest. In this regard, from fiscal year 2018 to 2023, DPSCS's healthcare costs increased by 41%, even though the average number of incarcerated individuals during this period declined by 18%. We also found that a fixed fee model is not commonly used by other states. A New York University law review published in 2020 found that healthcare providers, including the medical contractor used by DPSCS, typically used a capitation model where the contractor receives a flat rate per individual. Other states used a cost-plus model where the contractor was reimbursed for their actual expenses plus a fee for profit margin, which provides a little bit more transparency. DPSCS could not document that it considered either of these payment models in the procurements. DPSCS also cannot support that the staffing levels established in the contracts were sufficient to provide the required services to the individuals. The request for a proposal specified a number of health professionals the contractor was to provide at each facility. DPSCS couldn't explain how these numbers were developed, and we noted that the ratios of medical professionals to inmates varied significantly between facilities. For example, at one facility, the ratio of registered nurses to incarcerated individuals was 1 to 12, and at another facility, it was 1 to 502. Our audit also disclosed that the solicitations did not establish adequate hourly rates for the health professionals provided by the contractor. Specifically, the contractors were only required to pay these professionals, such as nurses, more than the state's hourly living wage, which at the time the medical contract was awarded was only $14.24 an hour. I'll touch on this more in the next finding, but these low rates appear to be a significant contributing factor to the contractor's inability to provide the required staffing at any point during the contract term. The contracts also did not require either contractor to obtain performance bonds to ensure the state was protected in the event the contractors could not perform. State law authorizes agencies to require these bonds for service contracts over $100,000. Given the numerous past performance issues with these contracts, we believe performance bonds were warranted. Moving on to finding 2 on slide 6, DPSCS awarded the contracts, the medical and mental health contracts, despite significant concerns with the proposals. DPSCS also did not disclose these concerns to the Board of Public Works and did not develop a contingency plan in the event that the contractors could not fulfill the requirements. DPSCS's evaluation of the medical and mental health contractors' proposals expressed concerns that the contractors would not be able to recruit and retain enough medical professionals. While DPSCS did not elaborate on these concerns, our analysis found that the hourly rates paid by the contractors for key positions were significantly below the statewide average. For example, in 2023, a registered nurse employed by the medical contractor would have been paid $25,500 less than a registered nurse paid at the statewide average. Similarly, under the mental health contract, a registered nurse would have been paid $19,500 less. In addition, 3 states that the medical contractor listed as references in its proposal had advised DPSCS that the contractor had challenges providing staff. Despite these concerns, DPSCS moved forward with awarding the contracts. They could not provide documentation to support this decision or any other considerations such as possibly resoliciting the services. We found no documentation to support that these concerns were disclosed to the Board of Public Works. The board noted that the medical contractor's proposal was nearly $50 million lower than the incumbent's proposal and questioned whether the contractor could perform without the need for more money in the future. DPSCS's response was that, quote, "The procurement was competitive and the contractor had demonstrated its ability to perform," unquote. While DPSCS advised that it may have disclosed these concerns during preliminary meetings with the board, there was no documentation to support this, and the employees responsible for the procurements are no longer with the agency. Given the concerns I mentioned and the contractor's subsequent failure to provide the minimum staffing and other deliverables that Rob will touch on in a second, during the entire contract period, this statement to the board appears unfounded. Finally, DPSCS did not develop a contingency plan in the event that the contractors could not meet the staffing requirements. Given the long prior history with these contracts and the concerns noted during the current procurement, a contingency plan may have helped address the staffing shortages, and the department could have pursued recovery of the related costs from the contractors. I'll now turn it over to Rob to present the rest of the findings in the report.
Good morning, members of the committee. My name is Robert Smith. I was the audit manager, and I will be presenting findings regarding the department's monitoring of the incarcerated healthcare contracts. Finding 3 is on slide 7. The department did not adequately monitor its contractors to ensure critical health exams were completed within the required timeframes. For example, the department only performed a review of intake screenings for 1 month during the 5-year contract period and found that almost half the screenings it reviewed were not completed. Additionally, the department did not follow up with the mental health contractor to ensure that missing suicide risk evaluations and mental health exams were completed. Between July and September 2023, the mental health contractor did not complete over 500 suicide risk evaluations and mental health exams. These screenings and exams are critical to address the health needs of incarcerated individuals and protecting its staff. Finding 4 is on slide 8. The department did not have comprehensive procedures to ensure that the medical contractor properly and timely resolved the medical-related complaints filed by incarcerated individuals. The nature of these complaints include concerns about medication and medical treatment. For example, not receiving prescribed medication. 17 of the 18 complaints we tested were not investigated in accordance with state regulations. For example, the contractor did not document that it interviewed the relevant medical professional or incarcerated individual. Also, the department could not support that it followed up with the contractor to address the untimely resolution of 10 complaints, which were resolved between 1 and 6 months late. State regulations provide that complaints are to be investigated and resolved within 45 days. Finding 5 is on slide 9. The contractor provided staffing reports monthly, and these reports were the primary means for the department to monitor the staff provided by the contractors and assess liquidated damages. However, the department did not attempt to verify the reports provided by the medical contractor. Additionally, the department only attempted to verify the mental health contractor staffing reports once, and it did not resolve discrepancies it identified, where the staffing reports did not agree to the contractor's timekeeping system. Finding 6 is on slide 10. The department did not have procedures to ensure payments for pharmaceuticals actually reflected the pharmaceuticals received. As of June 30th, 2024, payments to the pharmaceutical contractor totaled $161 million. We tested 10 payments totaling $7.6 million and requested documentation such as receiving reports to support that the pharmaceuticals paid for were actually received. However, the department could not provide support for these payments. Finding 8 is on slide 11. The department did not document the basis for a $20 million settlement agreement with the medical contractor that also waived liquidated damages totaling at least $40.5 million. Additionally, the department could not support the decision to reduce the staff provided by the contractor by 132 positions for the remainder of the contract period, and did not obtain approval from the Board of Public Works for reducing the staffing levels. Finding 9 is on slide 12. The department did not assess liquidated damages to the mental health contractor totaling $10.5 million between March 2022 and January 2024. Additionally, the department assessed liquidated damages to the medical contractor based on a statewide staffing level for each position instead of a per facility basis for each position as required by the contract. This reduced the amount of damages the department assessed, as it allowed facilities with full staffing to offset vacancies at other facilities. For example, the department failed to assess damages over $800,000 between October and December 2023. It should be noted that neither the medical nor mental health contractor provided the number of staff required for any month of their contracts that lasted over 5 years. I will now turn it over to Josh Adler to present findings in our audits of the Department of Central Operations and Maryland Correctional Enterprises.
Good morning, co-chairs and members of the committee. For the record, my name is Josh Adler. I'm a director of the Office of Legislative Audits, and I was one of the people responsible for our audits of the Department of Public Safety and Correctional Services Central Operations, and which I'll refer to as DPSCS, and the Maryland Correctional Enterprises, which I'll refer to as MCE. Beginning with Central Operations, which finding 1, which is on page 14 of our handout, we noted that DPSCS didn't ensure that employees who stopped working there were removed timely from the payroll records, resulting in improper payments totaling at least $173,000 made to former employees. So DPSCS generates payments to every active employee unless adjustments are made to deactivate them, such as when a person resigns. Our review found that only 1 employee was responsible for deactivating employees, and there was no supervisory review or approval of this process. Our review noted that during an approximately 5-year period, there were 154 employees who were deemed active for between 10 days and 860 days after they stopped working for DPSCS. Our tests of 7 of these employees found $173,000 in payments were improper. For example, the last day for 1 employee was in August 2016, but the termination date in DPSCS's payroll system wasn't recorded until June 2018, more than 2 years after the person separated from DPSCS, resulting in improper payments to this individual, this former employee, of over $58,000. Proceeding to finding 2, we found that DPSCS didn't have adequate controls over manually processed adjustments to both employee pay and leave balances. In regard to payroll adjustments, there wasn't any review prior to the adjustments being processed. Now, our review of 7 payroll adjustments related to payments for military leave found that all 7 were bad. For 4 adjustments resulted in overpayments, and 3 adjustments didn't have any support. So for example, 2 employees were paid $84,000 because the manual adjustments paid them their full salary at DPSCS rather than the difference between their military salary and their state salary as required. Proceeding to findings 3 and 4, which is on page 15 of our handout, we found that DPSCS issued 1,051 purchase orders totaling approximately $4.3 million without a formal competitive procurement process. DPSCS couldn't readily explain why the goods and services were procured weren't consolidated to maximize the high volume buying power. But because they weren't consolidated, certain of these contracts weren't subject to enhanced oversight of control agencies such as the Board of Public Works. We also identified a repeat finding in which DPSCS didn't always publish contract awards on eMaryland Marketplace as required by state procurement regulations was important because it adds transparency to the awards. We identified 9 contracts totaling $248 million who were either not published on eMaryland Marketplace or published 6 to 10 months late. Proceeding to Maryland Correctional Enterprises, MCE, which is on page 16 of our handout. By way of background, this unit develops programs to provide work experience or rehabilitation for eligible incarcerated individuals. Now, state law provides that MCE be financially self-supporting and that goods and services, such as furniture, be available to government agencies and nonprofits. The number of incarcerated individuals employed by MCE has declined significantly from approximately over 2,000 incarcerated individuals in 2010 to approximately 1,100 in 2023. Our audit found that MCE didn't adequately pursue the collection of delinquent accounts receivables. So, meaning that when people didn't pay, they didn't go after them, or when agencies didn't pay. Our test to 5 state agencies with accounts totaling $532,000 disclosed that 3 accounts totaling $70,000 have been outstanding for periods ranging from 261 days to 414 days, but MCE hadn't sent them a bill. And for the other 2 accounts tested, one was outstanding for 443 days until they got paid, and the other was still, while they sent the bills, they were still outstanding at 564 days. Moreover, during this process of the agencies not paying them, MCE continued to provide them with goods and services. We were advised, the Department of Budget and Management Central Collection Unit, referred to as CCU, that MCE can't refer delinquent accounts to it, and it needs to collect the debts by itself through escalating the delinquent accounts to senior leadership at the related agencies. However, we found that MCE hadn't done this. This concludes our presentation, and we'd be more than happy to answer any questions you may have.
Thank you for that very sobering report. It sounds like, at the get-go, from the beginning, that the way this procurement was laid out, it was almost doomed to fail, right? In terms of how, some of the terms were laid out, the follow-up, a lot of the structure in place on how this was being procured left us with a contract that, for many reasons, didn't meet certain standards and eventually failed in many different ways that you kind of outlined. Was that your sense?
Correct. If I could, I love quotes. This is a perfect example of fool me once, shame on you, fool me twice, 3 times, 4 times, 5 times, then shame on me. The department had experience with these specific contractors. Forget about other states. They themselves had past experience with these contractors. And so it was really the W&O, and I didn't bring this up in my earlier comments. I'd be remiss if I didn't say there are not a whole lot of contractors out there to begin with. That's A. And B, these are challenges that are being experienced in other states. But that is all the more reason why we think that the structure of the contract that needed to be specific to address the past performance and the ongoing concern. So that was a long answer to your quick question.
And it didn't, and we saw the outcome of this again, which is, again, falling short of a lot of the standards and expectations that we as a state has.
Correct, and you could see the same findings in that 2007, similar findings in the 2007 or in the 2017 report.
The department has said that there is no standard staffing model, so therefore they could not have been inconsistent. What is your take on responding to that? Because that's what they said in their written response back to the audit.
I'll turn it over to Eddie, but I think we're not public safety experts, and I want to make that clear. And that's why, if you look at the findings, we're saying, provide us with documentation so we could understand. That's our job. We walk into an agency, they're the experts on all these things, like staffing, healthcare contracts for inmates, and we ask them, hey, you procured this contract, show us the basis for how you determined your staffing needs. And that's what we couldn't see. And so therefore, we look to 2 different facilities and we see an anomaly. Eddie quoted some of those disparate ratios of 1 nurse for 12 inmates versus 500 at a different facility. And then we turn to them and say, explain the basis for these staffing needs. And that's what we couldn't find. So if there was no standard, well, that's exactly the point. We're looking for what the methodology was to establish those standards within those facilities. Eddie, anything else you'd add?
I would just add, I think it is a challenge that hasn't necessarily been solved by any states. But to our point is, or to Brian's point is, there are models that other states are using, and we decided not to use either of them, and there was no evidence that we considered either of those. And from our standpoint, it's primarily or principally a staffing contract to set up a payment model where we pay them the same amount regardless of if they meet full staffing or they fall well below the contract minimum. It just begs the question of whether that is really the best approach.
But they couldn't explain it. There was no documentation that you could find explaining what staffing ratios were present. There was no consistency there. There was no documentation.
Correct. I think some of that may be that the individuals who were responsible for the procurements were no longer there. But as far as documentation, that's what we rely on. We did not see any evidence. We were told we use the fixed model because that's what other states do. We tried to verify that for ourselves, and that's where you see that there are those other models, including the one that the medical contractor uses for other states.
In medicine, we know that documentation is everything. If we didn't document it, it virtually didn't happen. So it's troubling here that there's no documentation as to what the staffing levels should have been, or how they were developed, or what should have been sufficient levels. If it didn't document, it didn't happen. Last question here. In their response, in the department's response, they also contend that they selected a vendor that did not display any concerns that precluded them from being awarded this contract, number one. Number two, the reference checks didn't really matter in this instance. I'm just paraphrasing. And number three, that the OLA report states that no documentation was drafted to support the department's decision to award the contracts to respective contractors. So, they contend all this. What is your response as the auditors? Because that's what they've written in their response back to your audit report.
I guess I would say that to take the position that there were no concerns during this procurement, I just think is not an accurate statement. I think the outcome, as Brian has said several times, was entirely foreseeable based on the way the procurement was structured and the things that were identified during it. I mean, they specifically noted that they were concerned that the contractor would not be able to obtain enough staff to perform the services. I don't know, beyond that, how much worse does it need to be?
Okay. So your contention is that, they should have had documentation here, that there should have been more homework that was done in preparation for this contract being procured, and that didn't take place. Or at least there was nothing to show that.
Definitely we have issues with the structure, but I think what we're saying is even from what they did do, I think it was very evident that there were going to be challenges with the actual performance. That I don't think that we awarded the contract and then were surprised by the fact that the contractor couldn't meet the requirements.
That they should have been able to foresee some of the challenges that came
That's
forward.
correct.
Okay. Thank you. Chair Solomon?
Yeah, thank you to your team for the incredibly thorough presentation. So I did just want to sort of follow up on Senator Lamb's questions, because there was one piece in here that in particular really stuck out to me, and I wanted to get your response on it. So this sort of back and forth in their response that, oh, well, we actually didn't know. You mentioned on the reference checks, but this back and forth that, oh, we actually didn't find out. And you all say that this information was explicitly indicated in the contractor's technical proposal. So, I mean, this was there. That seems like there is no back and forth. Either it was in their proposal or it wasn't.
That's correct.
So it's pretty clear that they knew about this when they were competing it.
Yeah, I think the only possible question may be like very specific details of, what did they know, when did they know it? But at the time this was awarded, I think the major concerns were evident.
I mean, I would think if you find out that several states have already ended the contracts for exactly what you're competing, you would want to follow up with those states and figure out what went wrong. So that was concerning to me. And then, I wonder if maybe you could talk about, there does seem to be, again, sort of this back and forth that the procurement officer and evaluation committee looked at this and sort of gave them all clear. Is this the kind of thing that committee is looking at, or are they just sort of looking at, did the agency follow the correct procurement steps, or are they going to dig in and say, hey, wait a minute, there does seem to be this red flag. Have you actually followed up on it? I don't know if you can speak to that. Maybe that's a question more for the procurement folks.
It might be more of a question for them. But
Okay, all right, thank you.
Delegate Moon.
Delegate Aaron's.
Thank you, Mr. Chair. Thank you for this audit. And apologies, I came a little late, so I missed the top of your presentation. But, I mean, the context, I guess, I'm thinking about some of this in is I think we are being sued, have been sued, related to the healthcare contract and had a new procurement. But I guess as to the point about staffing ratios, this is, I mean, I'm on the Judiciary Committee, and the staffing ratios in the corrections system have confounded me for 10 years. And I really try to understand what's going on there, because it always seems the numbers are way out of whack and too low for what we're trying to do. So I'm just trying to discern from this, what's the system-wide staffing, health staffing ratio under this period of review that we're talking about? It talks about, like, there are little anecdotes here. It could be 12 to 502 per person, depending on the facility. But I guess, do you have some sense of, like, globally what that is? Because I kind of think it's important for the public to have this very specific discussion on the record, what it should be if our procurement seems to not be looking at this aspect of it at all. And I think you correctly note, isn't that what the whole contract is? It's a staffing contract. And I say this because I seem to recall hearing previously the numbers in the Hogan years sounding horrible. Like, wow, we have, like, 10,000 patients for, every one, I'm exaggerating, I think it was 1,000 to one health professional for every 1,000 people in the system. And I think in the latest iteration, I heard it had gotten worse. So do you have a vague idea of what that system-wide number is?
I don't. I think that might be a better question for the department. We had looked at individual positions, and those, understandably, those ratios are going to vary by position. We just noted that from facility to facility, they seem to have a pretty wide range.
But just so I'm, like, understanding this, is it looks like the case that system-wide in 2023, you might have had 120, 140 people that could vaguely have been called mental health professionals for the 17 or 18,000 people in the system in that year? Just looking at the chart, if that's accurate.
Yeah, so that chart is select positions, so it's not the entire number of staff, but it is the top categories. So I think that is a somewhat accurate assessment, is that it is just a couple hundred people for the 17,000 inmates.
Yeah, okay. And so if people just, again, everyone slots, 100, whatever, 200 people for 17,000 people in the system on a 24-hour, 7-day-a-week basis, it doesn't seem like that's much of a health ratio there. So you have, however, come across other states that do have some ideal staffing ratio number for these services?
We did not look at that on the audit. Our point was, the department put a specific number of people that needed to be supplied at each facility. And we looked at it as, what your average enrollment is at those facilities. There must have been some basis for that decision. We're not the experts on prison staffing and healthcare staffing. If we could see some rhyme and reason behind those decisions, I think we would have been happier about it. We just didn't see anything to support, how do we decide this facility needs 12 people, this one needs one person.
Got it. And I guess the added layer I'm putting on here is these numbers overall just seem horribly low. Like, how can this possibly work? It doesn't really, this isn't adding up to me. And so I guess it's just leading me back to, what is the basis of this procurement? Is it just cost, like, without regard to the size of the population or what the actual staffing model is? That's sort of a rhetorical question. I'll leave it there. My my other question following up on this is, did you encounter any analysis of what the health outcomes or outcomes generally of the people who missed these evaluation, suicide watch or whatever? Like, do we have some indication of whether bad things happened because of this?
I think that would be a better question for the department. It's related to what are the long-term impacts of that, and I think, that there's obviously been some discussion of that in the press about, the overall concerns with the healthcare system. I think there is an added component other than a lack of the analysis or the basis for the staffing. I think the dollar amounts being paid, especially in light of the concerns with the pricing that came in, can't be discounted. On a personal level, my daughter's a nurse, and we all know in the state that there's an incredible nursing shortage. If you want someone to work in a prison, I think you're going to have to be aggressive, or at least competitive with the current pricing for a nurse in order to go and fill those positions. So I think, there's a combination of three different things. One, the lack of a basis for some of the numbers that were put into the contract, both in total and within the facility, the lack of monitoring of that activity, and then the financial structure. Was it geared to make sure that the longstanding issues that we've had in meeting our staffing goals are we going to be successful based on the pricing model that they used?
Got it. And maybe this is another question for corrections, but we have a new procurement now, right? We flipped healthcare vendors, I think, and since this audit was done, okay. So you can't speak to whether the agency response indicates that these are not ongoing concerns in the current procurement?
I can't, but you can ask the question, overall staffing of the new contract compared to the staffing requests, or I'll call them requests, of this initial contract, how do they compare? Are they at par? Are they requiring more staffing? And what have they done to make sure that those staffing needs are adequate and are being achieved? The department would be better to answer those questions.
Got it. Yeah. And again, just my vague recollection was hearing about the new procurement in the news. The staffing level seemed crazily low. So thank you for the audit.
We do Delegate Lehman. Did Senator have one? No. Okay. So Delegate Lehman, then Delegate Harris.
Yeah, actually,
Delegate Arns. Okay.
And I would just reiterate, we will have the agency up here, so just, again, in the interest of time.
All right, I'll try to be quick. Thank you very much for the presentation. I guess I'm going to look at a different angle here. If you were going to fix this, where was the breakdown in all this? Because this sounds pretty elementary to me when you have something failing 2 times, that somebody somewhere is not doing what they need to do. Did this department just go rogue and say we don't care about anything anymore? Or how did we get to this point? Did you look at that at all?
We were looking for the thought process, the documentation for how did you come up with the methodology to procure this contract? And that's what was absent. And I think that's where the answer to your question would be found. How did they come up with the numbers and the approach and the decisions that were made in structuring this contract? And we didn't see any of that. And so I'm not saying it wasn't there. I'm saying we didn't see any evidence of it, and so we can't comment on it.
Well, the theme between a lot of these audits we've been going through is that people just don't know any better. I mean, we're looking at stuff, we're getting presentations from you saying that, well, this is happening, we know the staffing level is this, we know that. Who's failing in this model? Because is it at the highest level? Is it the people level? Where do you find a weakness that we need to start addressing as far as a state?
I think if this was the first procurement, you could talk about the people who are doing the procurement. I think given the long history and attention to the matter, I think at some point it's going to need some involvement and oversight from senior management at the agency. None of these things, and that's the advantage that I'm not going to look across other states. Just internally, the failures that we've had in meeting those staffing goals over decades should be enough for us to at least have a documented basis for decisions. And you're going to have trial and error. We'll try this approach because we want to try to solve a long-standing problem. But all that should be documented, because if you don't, then when you're procuring the next contract, how can you really pivot and find and address the shortcomings of the previous approach?
But removing people from payroll, that's not magic. That should not be something it should be. I quit, I'm done. Why are we continually seeing this? We've seen this in other audits, and it's in this department specifically over the past, but I guess I'm looking for the failure point. Is it at the highest level? Is it at the people level? Are we coming in there? You know, back when I was the county commissioner, I was saying this earlier, is that when I went in there and I had a problem with somebody in my county, I just said, you know what the response was? Well, you're gonna be here 4 years and you're gone. So how do we address that as a state and start getting the people in here to actually look at these positions and look at these jobs and say, you know what, this is a breakdown. We need to fix that. We need to put this on the pace and notice it and fix it today. These are millions and millions of dollars we're dealing with the taxpayers' money. And we're not doing that effectively. And I don't know where we or how we could address that without more information and actually finger pointing, if you will.
I think the department can talk about the specific people involved. I can tell you that most of our findings are cases where there are procedures in place, but they're just not being followed. And so when we look at the responses, and I think that's where oversight, you know, we're gonna do this. Well, that's not an answer. The answer is, what steps are we gonna take to make sure that these things are gonna happen?
So they don't happen and we do nothing about it. Is that it?
Correct. You know, you can have good intentions, but what procedures are you putting in place? I'll take the payroll, taking people off the payroll. It's not automatic. People in the state get paid on a negative basis. In other words, your payroll check is going to come every 2 weeks unless something happens. And so therefore, when someone leaves, there needs to be a checklist of things that people go through to make sure that one of the steps is you remove them from the payroll. But there needs to be a control in place to make sure that that process is happening consistently. And that's where I think that, you know, to fix these problems, processes are there for most agencies, but there's no process to monitor them. And often what we're finding is when there is an audit shop, they're being relegated to doing some of the actual monitoring instead of the monitoring of the monitoring to make sure things are working as intended. But the department could address the specifics, you know, as it relates.
But we see this in everyday business. Businesses do this today and they succeed. We're not succeeding. In my business, if your job is to take him off the payroll or someone off the payroll, and you don't do that, there's a consequence. Why are they not? Are they not in our purview, or what do we do? Is that just not happening?
Within the agency?
Yeah.
Again, that would require you to be able to pinpoint and point the finger to one place. If I can give one short analogy, and I know it's short. I once went, it was the holiday season, I went to go buy a pair of shoes, and I went into the store and brought it up to the counter, and the person said, we're having a sale, 10% off. And I said, well, how many if I get 2? And the clerk said, well, then you'd get 20% off. And then I said, then give me 2. And, you know, push comes to shove, when the person tried to ring up that transaction, the company that was responsible for that store said, we're not going to allow this to fall to error. And there was no way for them to make that mistake because there was a control in place to prevent that from happening.
And you're saying we don't have that?
And I think that's where we need to work on, especially for things as simple, and I'm going to say simple. The healthcare contract, complicated.
With all due respect, we hear this in every audit, and we're not addressing that somehow, some way. How do we, as a group, address those problems? Because that doesn't necessarily happen in the real world, but it happens a lot in these audits. And I would like to know if you have suggestions on how we fix that.
Today?
No, it's a rhetorical question. I appreciate, you know where I'm going with it. I apologize. Thank you, Mr. Chairs.
Okay. Thank you. Am I on? Yeah, thank you. Thank you to the 2 chairs, and this is my first meeting in person, and I'm glad to be here. It's an honor to be here, and thank you, gentlemen, for your work. I have first a request that whoever answers any questions, some of you are hard to hear. If you could pull your microphones closer when you're speaking, that would be helpful. So this is troubling, to put it mildly. And so first of all, I was curious when it's all troubling, but especially where there are repeat findings. So how long ago was your last audit of this agency, and when would your next audit be?
Our last audit report of the central operations audit was dated November 20th, 2019. And I believe this agency is on
I'm sorry, what was the year?
November 2019. And so we'd be going back out there in about 3 to 4 years.
Okay, and then at the end, you say we'll assess the status of the recommendations during our next audit. When would that be?
That's the audit I'm referring to. There are 3 audit reports being addressed here, but the ones dealing with the central operations and the healthcare, we would address that during our next central operations audit, which should be in about 3, I'd say, somewhere between 3 and 4 years from the date of this report.
Okay, thank you for that. You know, I can't help thinking about all these lawmakers in this room, and if we were thought to be doing any one of these things, we'd be hauled before the Ethics Commission, and if the findings came back, you know, any one of these findings, we would be publicly shamed, and rightly so. We'd be fined, and there would probably be other sanctions. So my question is, between now and when you made these recommendations to the agency, and then you're going to have this follow-up audit, but between now and then, what recourse is there for all this, for lack of a better term, bad behavior, this mismanagement and such? What are the possibilities? Are there any clawback provisions, for example, in these contracts, or to get the money back from employees who were overpaid, employees that shouldn't have been paid at all, that are not even with the agency anymore? What happened? Is there something that can happen between now and your next audit, something meaningful?
So our audit report does address recovery of the funds for the employees that were overpaid, and the department, I believe, has agreed to go and pursue that. As far as the healthcare contract, there are provisions for liquidated damages, but there is a new contract out there that the department can discuss. The problem is that contracts last 4 years. When we're dealing with providing health care, and that's why we brought up that contingency thing, it can't wait. We could assess liquidated damages, but tomorrow, if there's still a staffing shortage, someone is the recipient of that lack of health care. And so that's where I think if we're going to acknowledge that this is a challenge, what are we doing tomorrow to address those needs? Do we need to have a supplemental contract, just per diem nurses or something like that, to fill in the gap? I don't know. That's what that's what we think that the department should consider, or try to at least develop a plan to go and address. But it's not something that could wait for, hey, 3 years till the next contract, we'll make it better. Because the long history that the department has had and previous audit reports has shown that that's not working. And so I don't think this is a case of more frequent audits. They have plenty of audits. They have plenty of, blueprint as far as, problems are concerned, to go and start on a corrective action plan. It's not a matter of additional monitoring. It's a matter of them taking action to address or change what has been the standard to go and get a different outcome.
Any other questions? In the meantime, the department's entered into a new contract, and hopefully they've done better.
They could perhaps tell you what the new contract is going to provide that this one didn't.
We'll see. With that, thank you to Mr. Tan and your team. Next, we have to come before us the Department of Public Safety and Correctional Services, and we'll ask Secretary Scruggs to come up with her team. Madam Secretary, you can go ahead and introduce your team and proceed.
Good morning, Chair Lamb, Chair Solomon, members of the committee. For the record, good morning, Chair Lamb, Chair Solomon, members of the committee. For the record, my name is Carolyn J. Scruggs, and I'm the Secretary of the Maryland Department of Public Safety and Correctional Services. With me today are Deputy Secretary of Administration, Joe Sadal, and Assistant Secretary for Programs, Treatment, and Reentry Services, Bernard Brooks. I'd like to thank the Office of Legislative Audits and their team for their partnership throughout the process. As this body is aware, the department oversees 13 state correctional facilities and 5 pretrial facilities located within the Baltimore pretrial complex. The current DPSCS population is 18,000 547 individuals under our care and custody. In addition, the department operates the Division of Parole and Probation, which is responsible for supervision of individuals in the community that are currently 44,268 individuals under our supervision throughout the state. I want to first begin by acknowledging the significant work of the OLA. We concur with the majority of the audit findings and all but one of the recommendations and have already begun to address them. We have concerns regarding some of the assessments and will provide additional clarity. Although many of these findings are based on actions taken prior to our leadership, the responsibility lies with us to bring corrections to corrections to the findings within our department as we move forward. I'm committed to doing my utmost alongside my dedicated team to address and rectify the findings the audits addressed today. This will help increase accountability and make significant improvements as we move forward. I'd like to begin with MCE. The Maryland Correctional Enterprise provides structural training activities for participants in order to improve employability upon release, to enhance their safety and security by reducing prison idleness, and to produce quality goods while remaining a financially self-supporting agency. The department concurs with the assessment and recommendations of OLA audit of MCE. The majority of the audit period covered, which was from April 1, 2019 through June 30th, 2023, occurred under the previous administration. As a corrective action, MCE will now perform age receivable reports within 5 days at the end of each month to identify past due invoices. Since July 2024, DPSCS has resolved 15 past due accounts and reduced the DPSCS past due balance from nearly $1 million to under $320,000, over 60% reduction. MCE has sent out notices to state agencies with past due balances and escalated that problem to leadership. In fact, I can share with you that I have talked with numerous secretaries that had balances that were owed. One was up to $2 million, and we immediately got payment the next day for that. So once it was escalated up and I was able to confer with those other secretaries, we started to see those monies coming in. Finally, 5 non-state agencies with balances of 90 days or more have been sent to Central Collection Unit. Moving on to Central Operations, the entire period covered by Central Operations audit, which was from April 1, 2018 through May 31st, 2022, was under the previous administration. This administration graciously accepts the recommendations of the OLA and takes pride in ensuring corrective action is being taken to address all of the recommendations and improve the operational processes. Finding 1, an independent supervisory review is currently being conducted to ensure the accuracy of termination dates in the Maryland statewide personnel system. Payroll is investigating payments to employees, post-separation date, to identify overpayments and pursue recovery. Finding number 2, payroll continues to review manually prepared listings of payroll adjustments and verify SPS workday output reports. We are ensuring backup documentation is in place for leave balance adjustments and pay calculations, and are investigating overpayments to take the necessary action for recovery. Finding number 3, we are communicating with DGS to ensure goods and services are purchased at the best value. Control agency approvals are in place and split purchases are prohibited. Finding number 4, awards are appropriately being published on the eMaryland Marketplace Advantage as required and are monitored on a bi-weekly basis by a quality assurance and quality control team within our procurement unit. Moving on to our healthcare contract. It should be noted that the majority of the audit period covered, from April 1, 2018 through December 31st, 2023 is again under the previous administration. Under my leadership and recognizing areas in need of improvement, many of the OLA recommendations were implemented prior to receipt of this audit, and we have begun to address many of the other recommendations which are outlined in our written response. We respectfully disagree with only one of the recommendations. We also have different perspectives within certain aspects of a number of the findings, and we will provide additional clarity on our differences within those findings today. The previous medical contract with YesCare, formerly known as Corizon, was solicited in 2017. It was executed January 1, 2019, and it expired July 31st, 2024. The previous mental health contract with Centurion was solicited in 2016, executed on December 1st, 2017, and expired July 31st, 2024. Both of these contracts were the subject of the audits. The fact that the department had already begun to implement many of the recommendations before the OLA issued them in writing demonstrates our ongoing commitment to improving healthcare services and addressing the identified issues raised in the audit, underscoring the department's dedication to enhancing healthcare delivery and minimizing disruptions for those under our care. Additionally, it is worth noting that workplace operations prior to COVID-19 pandemic differed significantly from current practices. At that time, many meetings and collaborations occurred organically, and a dynamic that has since shifted in the post-pandemic hybrid virtual in-person work environment. The OLA response on finding 1, stating levels were inconsistent, is factually inaccurate. While we respect the conclusions drawn in the report, we respectfully disagree with this. As stated in our written response, staffing levels are determined based on the population size, specific policies, and healthcare needs of each facility. A one-size-fits-all approach would not apply. Variations in staffing reflect the tailored needs of each facility, ensuring appropriate care for the incarcerated population at that location. For the mental health contract, staffing requirements were set to address the individual needs of each facility population as well. Given those needs, staffing levels would differ between facilities and should not be expected to be consistent across all locations. For the medical health contract, the staffing plan was developed based on a thorough review with the National Commission of Correctional Health Care standard that emphasizes staffing decisions are based on factors such as facility size, service scope, incarcerated healthcare needs, and organizational structure rather than fixed staffing ratios. DPSCS adhered to these guidelines to ensure healthcare services met contemporary standards of care and effectively addressed the needs of the incarcerated population. We respectfully disagree with OLA's final response in finding 2. First, the original audit finding 3 states the medical health care listed as references had advised DPSCS that the contractor had challenges providing staff and that the contractor had recently terminated contracts with other states is not an accurate statement. Neither the evaluation committee or the references indicated that the contractor had multiple terminated contracts with other states. The medical contractor's technical proposal includes a history of 2 terminated contracts. However, one contract was terminated without cause, and the other contract was terminated due to the medical contractor's inability to provide the required staff, neither of which applied to the DPSCS contract, which is why they were not included in the evaluation committee notes. The OLA failed to recognize the circumstances of this contract did not apply to the DPSCS contract. Second, the recommendation to create a contingency plan for every medical mental health contract is not a practical solution and would impose administrative burdens on the department without guaranteeing improved outcome. The department operates under COMAR regulations, which already include robust contingency mechanisms such as termination for convenience, liquidated damages, cure notices, to effectively address contractual performance issues. It is important to emphasize that the audit finding was made with the benefit of hindsight. At the time of the contract award, there was no reasonable basis to anticipate poor performance by the medical contractor. The evaluation committee conducted a thorough review of the medical contractor's technical and financial proposals, which raised no concerns. Reference checks graded the contractor highly, and the terminated contracts disclosed in the contractor's technical proposal were not attributable to the contractor's fault. These factors provided the department with reasonable confidence in the contractor's ability to perform as required. Finding number 3. As it relates to timeframes for critical health evaluations, when the OLA came back to begin this audit, the DPSCS was already performing audits of medical intake exams, annual physical exams, and mental health intake exams. This administration has developed comprehensive written audit procedures to ensure the contractors properly complete critical medical and mental health examinations within the requirements. Under finding 4, in regards to the timely resolution of medical complaints filed by incarcerated individuals, written procedures have been established to ensure the incarcerated individuals' complaints are properly investigated and resolved timely. With respect to finding number 5, DPSCS will verify the accuracy of the contractor supplied staffing reports, and we will follow up with errors in the reported data as identified. We will establish written procedures to verify that pharmaceuticals invoiced were received by the facilities as recommended by the OLA finding 6. We respectfully disagree with the OLA finding response 8. The referenced events described occurred during the unprecedented COVID-19 pandemic, and as a result of extraordinary circumstances, accommodations were made for the medical contractor, where staffing and operation issues in the healthcare field were pervasive at the time. DPSCS identified merit in several contractor claims, including Medicaid deductions, COVID services, outdated RFP information, and issues caused by the prior contractor's performance. By fall 2022, all claims were held in anticipation of settlement, which would have been approximately $40 million. A retroactive waiver of liquidated damages was deemed necessary due to widespread staffing challenges during COVID-19 pandemic. A fiscal analysis in November 2022 confirmed sufficient funds were available in the contract to cover settlement without requiring additional funding. Given the likelihood that the contractor would succeed on many claims, it was determined in agreement with the Attorney General that the $20 million settlement agreement was in the best interest of the department and the individuals under its care. This action was considered a matter of contract administration and was consistent with the way settlement of contract disputes has been resolved in the past. We respectfully disagree with OLA's assessment in finding 9, the assertion that DPSCS did not assess liquidated damages on the mental health contract as stipulated in the contract, and that damages assessed on the medical contract were significantly lower than provided for and overlooked the exceptional circumstances brought about by COVID-19. Prior to COVID-19, liquidated damages were assessed per the contractual agreement. During COVID-19, assessing such penalties would have been counterproductive and detrimental to the overall goal of remaining critical healthcare services given the staffing challenges that were present. It was not in the state's best interest to enforce the liquidated damages provisions during this period. In addition, the period without liquidated damages occurred after the contract claims were filed, and the $20 million settlement nullified the collection of those damages. Therefore, the decision in line with the settlement terms and the need to prioritize public health over penalties during an unprecedented emergency. We appreciate the opportunity to respond to the audit findings, and we will continue to address and focus on continued departmental progress. With that, my team and I are available for any questions.
All right, thank you, Madam Secretary. You know, as a baseline, just to level set, these individuals that are incarcerated are sentenced to prison. They're not sentenced to inadequate health, to lasting medical complications, and potentially to lasting, harm. It seems as though that health is secondary to the department's addressing of these individuals' needs. And these are individuals that are under the care of the state. We have chosen to incarcerate them, and we do need to care about their health. And I do recognize that at the very end there, you said that, you prioritize public health. It's not evident from how this contract was procured. It looks like it was really a contract that was looking at costs above all else, to Delegate Moon's point, that this contract seemed doomed from the get-go in terms of how it was set up and established in the structure of these procurement provisions. And it was really looking at the cost of it over everything else. And health seemed a far second to the department's priorities when it comes to addressing this. Even the fact of not having a contingency plan. These are people's health that we're talking about. These are people that can't get health care because we've incarcerated them. Their health is dependent on us. And so to say that there's no contingency plan when it deals with someone's health that's under the state's care is simply unacceptable. Can you explain how, to us, you feel that this wasn't a decision that was primarily driven by cost to the department when the department entered into procurement for a fixed fee contract? That makes it pretty obvious that it's really just the cost above everything else.
So thank you. Go ahead.
And to the new contract that's been put out, was that also a fixed fee contract that we've now entered into since this audit has come out?
So thank you for your comments and your question. I'll start off and then I will let my DSA finish. Let me first reiterate that this contract was procured under the previous administration. No one that you see sitting before you was originally a part of that procurement, so we cannot talk to the behavior. I can speak to the behavior with the new contract, which many of us have been an instrumental part of, and which we took the time to review contracts from many states to look at best practices to ensure that we were providing quality health care in every area. Health and safety is very important to us, as well as the continuity of that care when those individuals leave from us, because if those inmates are safe, then our staff are also safe. As far as the contingency planning, I'll let Mr. Sadal answer that for you.
But before we get there, with all due respect, Madam Secretary, you were in the department under the prior administration as well. You were in Mr. Brooks's seat.
No, not when this happened. I was a warden at MRDCC. In 2017, I was a warden.
When did you become the assistant secretary?
Deputy secretary for corrections. That was 18, I believe it was.
Were you ever
late
the
18.
assistant secretary for programs and treatment and reentry services?
I was.
When were you that?
I came in there late 19. You're
in
correct.
late 19.
So I did pick up the end of this contract. You're correct.
Okay. Mr. Settle, do you want to go ahead and address the contingency plan?
Thank you. Yeah, I mean, I think, and maybe this is just a a context issue, but when we look at state procurement, Title 21, the OLA asks for some level of contingency plan, some document saying if this goes XYZ south, whatever you want to say, that there's some sort of a plan in place. I look at Title 21 in COMAR as functionally the contingency plan. We have all of the remedies through state finance and procurement, through Title 21 in COMAR related to state procurement for in the event a contract doesn't go the way we want, how to react to it. There's not only, as the Secretary mentioned, things like liquidated damages and cure notices actually through the operation and monitoring of a contract, but there is emergency procurement, expedited procurement, modifications, all the things necessary to either make a contract better or to replace a contract, termination for default versus termination for convenience, are all in COMAR. So I think really our contention is primarily that it's there. We have the law that we can utilize in the event that a contract does not go the way we anticipated. And again, I think going back to some of the comments made earlier, whenever you enter into a procurement, the expectation, if you are recommending it for award, is success. But we have, through the mandatory contract terms that are stipulated through the Office of State Procurement and through state law, all of the available remedies to provide corrective action to any contractor that comes out. So maybe this is a question of what defines a quote-unquote contingency plan, but I think we're of the belief that we have the law and we're able to utilize the law to make whatever fixes or remedies are necessary. And there's a process in place to do that.
But it wasn't evident that you undertook steps to address the shortcomings that were obviously articulated and evident in the audit findings. That when there are hundreds of inmates that don't receive suicide screening when they're entering into our facilities, that seems like that should trigger some kind of contingency plan, shouldn't it?
I mean, I think an instance like that, if under a new contract, if something like that were occurring, right, we have those remedies related to cure notices, liquidated damages, all of these things that both provide a financial remedy as well as the possibility to procure separate contracts. These are all things that are already there in law. So as far as whether or not that was done under the previous contract, because as we all know, this is a contract that no longer exists, right? We have moved on to a new contract, and I think we're happy to talk about many of the OLA recommendations that have been put forward that we've already implemented within this new contract,
So your contention is that the law allows for contingency, but I'm still not hearing a specific plan. That, you can say that there are provisions in the law that allow for contingencies, but it doesn't mean the department came up with a plan on how to address this. A plan is how you would use legal powers in case something actually goes wrong.
So if I can address the intake issues, and I think if I remember correctly in the audit, there were some 584 intakes that they say were not done. We really want to see more in-depth information related to that, because each and every individual that comes through intake every day is completed what's called an IMMS. That's the Inmate Mental Health and Medical Screening. That is done immediately before we even accept you into a pretrial facility. Determines what your medical needs and what your mental health needs are at the pretrial stage, so that should you get a bail or stay with us awaiting to go to court, we're able to have that continuity of care. Again, once you are sentenced within the Division of Corrections, that inmate medical and mental health screening is redone. And at that point, within 7 days, you get a full physical. I can only speculate, but there are times in which our systems are down. So if the audit did use our OCMS system to track some of those, my question is, did they go back to the medical paper files that we revert to when we are, when our systems are down for us to do that? But each and every individual gets that medical and mental health screening.
You also contend that there's differences in staffing, and that may be appropriate depending on the facility. But what the auditors couldn't find is any documentation explaining the differences in the staffing of those facilities. That if you're determining that there may be different formulas being used or different requirements based on how those facilities are set up, there should be documentation for that, should there not? And why was that not accessible to the auditors?
So I cannot speak specifically to the previous audit, but this for this contract, the attachment R in the contract is the staffing analysis. During that, in the attachment R, it is enumerated by facility and based on the number of chronic individuals you have there, whether it's a hospital there, whether there is an infirmary there, and the patient care that's needed, whether that's the facility that houses your your impaired population, your blind population, or your hearing impaired population. So we do look at populations, and we also put in flexibility should individuals have to be transferred because their classifications change. And that is enumerated in attachment R, which did not change much from the previous. Now, how frequently that was reviewed, I do know that when I came on board, we had developed the audit unit within pretrial treatment and services. It was newly developed. And that team at that medical audit unit was actually reviewing all of that staffing at that point.
Can you follow up with us to provide the documentation on how you come up with your staffing levels for different facilities?
The staffing levels for those facilities. So the population is based on capacity that we can hold, and then classification. So we have facilities either defined as maximum security, which are our far-reaching facilities in the west. We have medium facilities that are basically in our Jessup area, and of course our pretrial complexes downtown.
So you're describing policies, because that's something that you can share with us.
Absolutely. We have a full case management manual that tells you how we classify individuals so that we can place them. And we're happy that it's on the internet. We're happy to share the case management manual with you that outlines all of that.
You also contend that a lot of this, you mentioned repeatedly that it was under the prior administration, but in the audit, it said, just reading out of it, our test of 10 of these individuals disclosed that as of June 2024, just a few months ago, 8 individuals had still not received either a suicide risk evaluation or a mental health exam. That's still just this year. And so it's easy to wave this off as a prior administration, of which you were a part of, but that's still carrying forward to this very year, just a few months ago.
So we are in no way trying to wave this off, sir. Let me clarify that. We are not trying to wave this off. We take responsibility and care of each and every one of our inmates and incarcerated individuals, and if there is a need to review and adjust, we do accordingly.
So I would just urge you to understand that when the state incarcerates individuals, their health and well-being becomes our responsibility. The judicial system may have sentenced them to prison, but they didn't sentence them to heart failure. Thank you.
Thank you for being here. And I would just echo the concerns of Senator Lamb. I think many of us on the committee would be very interested to see the very clear understanding of the ratio piece. I mean, again, 17 registered nurses to 201 inmates in some facilities versus 1 registered nurse for 502, I think it's just a little bit of a head scratcher. So if you have policy that clearly articulates why those decisions were made, I think this committee would very much want to see that. I wanted to just hone in on the salary piece, and I guess I sort of share my colleagues' a little frustration here. Obviously, you were not responsible for the procurement. You were in a different position. But it seems to me, based on the job description of the assistant secretary position, you were responsible for executing on that contract for the 4 years that you were in that role. So I guess I don't understand that if there were issues that were identified, obviously you were limited to what the scope of the procurement was, but there were plenty of change orders made in between. And I'm having a hard time reconciling why you say this is somebody else's responsibility and the actual execution of the contract was not yours in that position.
No, I said that we take responsibility for this. And I also just mentioned that during that time when I was the assistant secretary, we created an audit unit, the medical audit unit, which is fully staffed now with, I believe, and Mr. Brooks can explain more, I think they're up to 6 or 7 auditors now. And their sole responsibility, which we were developing during the time that I was there, was to audit every line item that's associated with performance, staffing, anything that would end up with liquidated damages or causes default to the contract. We had some turnover during that time because we did get rid of some staff that were in a smaller unit that had been defined to do that, and we brought in new staff that were more equipped and had auditing background.
So that maybe you can answer I want to move on to a different topic in a second, but the piece on the staffing, the salaries, And I know that there was some discrepancy. You claim in the response here that the OLA team is looking at 2023, which is a different time period. Their justification seems pretty straightforward, that they have not been able to get any documentation from you all. I mean, looking at the chart of the salaries, I mean, obviously, we know our healthcare employees are in the highest need fields, period. And so when you look down the line and you see that on average, it's about 25% less that we're paying somebody to work in a prison, when if anything, we probably should be paying them 25% more for a job that is even more difficult than a traditional healthcare setting, which obviously has only gotten more difficult since COVID. I didn't see anything in here, and maybe you all can produce this documentation to prove to us that the salaries were on par even before COVID.
So what I'll say to you is that Mr. Brooks was part of the new evaluation committee, and I'm hoping he can speak to that.
Thank you very much. A lot of important information has been touched on today, and some of it I would like to respond to, starting with that question first. I can only speak to from the time that I came back to the department 1 year ago, July 1st, and was a part of the team.
I just want to pause for a second because I want to hear what we're doing now.
That's what I'm going to tell you.
Right, but I also want to know, because this is in dispute in here. You're saying that the OLA, you say in black and white in here that the OLA information is wrong, that they did not accurately produce salary data to reflect under the previous contract. And so what I want to know, I want to hear what we're doing future, but what happened under the previous contract is not just water under the bridge. I would like to know if the agency can produce salary scales from pre-COVID, as you were saying, because clearly that goes to liquidated damages. If we are saying that the contractor put forward a salary scale that was grossly inadequate to meet our staffing needs, then this was doomed to failure from the start, as clearly OLA has said. So I want to know what we're doing future, but I don't want to just gloss over. And again, Madam Secretary, you are responsible for executing this contract. And if you saw a problem with the salary scales, I mean, frankly, especially post-COVID, we should have been paying probably 25 or 30% more. And I don't recall ever having a red flag go up to the Budget Committee saying, we need millions of dollars more. Obviously, we had we literally had trillions of dollars, billions of dollars in COVID relief money that we got from the federal government. And I do not remember, it's possible it happened, that we got any red flag saying we need to dramatically increase the pay of our healthcare staff so we can recruit adequately. Because again, what I'm seeing in here is that we were 25% below, even just on par with the same positions, let alone take into account that you're working in a prison and not in a hospital.
And we can go back and give you that documentation. I do recall the red flag did go up. It was approximately $3 million increase that was given to them because of the challenges that they were having during COVID, procuring staffing. It allowed us to bring in traveling nurses from across the country that actually came and relocated to Maryland because they were able to pay them at that higher rate. And they also were able to get PRNs from subcontractors, medical subcontractors, to come in and supplement some of those needs. So happy to go back and get that information and provide it for you.
Thank you. And then go ahead.
Okay. So speaking on the new contract, myself, along with the administrative team of Dr. Jerkins, Dr. Vineski, we had a team that looked at all of the contracts. There was 3 that were provided for the new one that was just awarded August 1st of this year. And painstakingly went through every single page, thousands of pages of their written response to that RFP. And a lot of what was said here today is obviously true. In the past, it was looked at as the lowest bid. I mean, nobody can get away from that. And the company that was currently in place, the Yes Care, in my opinion, I'm going to put it this way, had the audacity to write the lowest bid again, knowing that their performance wasn't up to par with what the department needed. So we did not go with the lowest bid. We went with the next highest bid, who demonstrated in their proposal what they were going to do in black and white. And trust me, as long as I'm there, they will be held to every single letter of what they quoted, because that's what I quoted to the CEO. This is what you said you're going to do. This is what we're going to hold you accountable to do. The salaries are higher in this new contract. When it comes to looking at staffing,
can you produce, I don't mean to interrupt, but obviously we're not privy to the procurement piece. Can you produce the salary scale that's in the new contract and show to us that they're on par?
as that.
Can I speak to that?
Yes.
Sure.
So one of the requirements within the new RFP is that all salaries must be a minimum of the 75th percentile according to the Bureau of Labor Statistics, and that's not nationwide, that's to the Towson, I think it's like Towson, Baltimore, DC region, however Bureau of Labor Statistics creates that. And that's a requirement, right? And I think one of the reasons we did this, and there is an increased cost as a result of that, is to ensure, as one of y'all said earlier, that no matter what, this contract, given the context of they're working in a facility versus working in a care provider facility anywhere that isn't jail, that it is competitive. We didn't look for the median, 75th percentile. And so they are required to provide those salary scales and ensure that we are able to, based on a federal guideline, able to validate that those salaries are in line with what the Bureau of Labor Statistics produces.
Are we worried that even the 75th percentile is, again, setting us up for, I mean, look, if I'm a nurse and I have the option to go work in a pediatric setting, in a hospital versus a prison, I'm probably going to choose the hospital setting. So to me, going to the 75th percentile means you're already not paying on par, right? And you're also not bumping any salary up to say, we know working in a prison is a difficult task. We've had this conversation with our other state employees and the recruiting challenges that go into corrections and go into parole. These are very difficult jobs. So it would seem to me that the 75th percentile, we're already sort of setting ourselves up for failure, because not only are we not recognizing that there's probably a bonus that is needed to recruit staff, but we're not even paying you potentially on par with what a private hospital setting would be paying.
If I may, I don't agree with that, your context that that's not on par, right? The 75th percentile is saying that when you look at all of the salaries that are reported and the median is going to be your 50%, we're 25% higher than that, right? We are in that third quartile, and obviously there's a fluctuating range associated with that. It's not, 25% more. It's all based on all of the reported salary statistics. So I think what we're doing by this is saying, baseline what the salaries are that are out there, we're giving you significantly more. We're requiring that offering to be more. And again, this is coupled with, there's also liquidated damages associated with staffing. So not only are we requiring that salaries be paid at this elevated level based on the median associated according to the Bureau of Labor Statistics and the market itself, but in the event that the vendor is not able to provide staffing, they will pay for it, right? They're losing money as associated with that. So, and I do think in that regard, we're kind of hitting it from both sides of saying you need to pay a lot of money to ensure that you are competitive. And further, if you don't, you will pay us back.
Well, I guess the proof will be in the pudding, and I'm glad to hear your assessment that you will hold them to every letter of the law. So I did just want to quickly move to the damages piece. So it says in here that it was in the state's best interest that we, again, decided to negotiate a settlement with the contractor where we essentially paid them $20 million, but we waived $40.5 million worth of possible damages. When you said it's in the state's best interest, who made that determination?
So that decision was made in conjunction with the Attorney General. Our attorneys guided us through that after looking at the numerous claims that had been made and the potential of them us going to court and being sued.
I guess I find it sort of hard to square the circle where we've, and especially by your previous statement, I mean, this previous contractor has declared bankruptcy. They are in the process of litigating numerous lawsuits from inmates. They've been dropped by numerous states. You have spoken ill of them. I know the statements from the BPW members during the previous procurement spoke pretty heinously of them. And I guess I don't understand how we just decided to waive 40, that even with all of that, we decided we're not even going to try to figure out how to get some of this back.
So again, we were guided by our attorneys. I will tell you that even though I sat as assistant secretary at that point, I was not a part of those negotiations. It fell on me eventually at the end because it transitioned over, but those negotiations were then being held by the then secretary, the attorney general, and the deputy secretary of operations that was on site. I was removed from that process.
And so you don't have any ability, because I'm going to just go through here. So do you know why the statewide approach for staffing level was used instead of a per facility basis, which lost us a significant amount of money, it seems like, and written in the contract it said you were supposed to use a per facility calculation as opposed to a statewide calculation?
Again, those discussions were being held at higher levels than me. They did remove that. Even though medical came under me, they removed that from my responsibility. And they were having those higher level conversations with the president of that company at that time.
So as the current secretary, let me ask you this. The contract just ended. What are you doing? There was, one of your responses in here was we need to consult with our legal team. Is there anything currently underway, any conversations currently underway with the current Attorney General to go back and some of these were things that literally happened this past year. And so it seemed to me, again, without seeing the contract, that we're still within the scope of time that you could go back and open up conversations for damages.
My understanding is a part of the $20 million settlement was that we waived those liquidated damages. So
Right, but
that
there's
was part of
newer-
the settlement.
There's
that was
newer
in
pieces.
there.
That settlement was. So recommendation 9B, your response was the department included liquidated calculations that have been developed with necessary requirements to fulfill the new contract, the feasibility of assessing additional retroactive liquidated damages for instances in which the previous contract's original amounts were not calculated in accordance with the contract or was based on inaccurate staffing, quote, is a legal question which will need to be reviewed by legal counsel.
Yeah, so if I may, as the secretary stated, right, there were numerous claims that were put forth throughout the term of the contract. And ultimately, there was a settlement agreement that the state determined was in the best interest. And as y'all know, any sort of a settlement, like any other negotiation, encompasses all elements of discussion, right? You look at, it's a risk analysis. You look at what is the feasibility, both administratively and cost, that comes forward with pursuing continuous litigation versus settling, resolving all claims, in this case, resolving all claims and making,
I just want to stop you for 1 second. So again, in your response here on page 12 of the response document, this is under finding 8, these settlement negotiations were done in November of 2022.
Yep.
So did that settlement essentially
No.
waive all, right, so from November of 2022, whenever the settlement was officially executed, 2023 and at least half of 2024.
And we've been able to. Yeah, I think to answer your question is previously, if we're talking about looking back during that time, then that's all resolved within a settlement agreement. But as far as beyond the settlement agreement, the department has been able to assess liquidated damages and has assessed liquidated damages throughout the term. As of now, the contract has expired, and I think we're currently auditing certain elements related to Medicare pricing for that final invoice payment before making that payment to the previous vendor.
So there's nothing we're going to go back on.
Well, again, I think what I'm saying is since the settlement agreement, if I remember correctly, the settlement agreement something like a 70-day kind of period of delay or no assessment. But beyond that time, liquidated damages were able to be assessed, and those were assessed. So looking back beyond previous to the settlement agreement and all those existing claims, absolutely, there's nothing that can be done about that. But as what is occurring right now and what has been on a monthly auditing and monthly invoicing basis has had liquidated damages assessed when appropriate.
So again, you have an outstanding question here that says this is going to be completed January 6th of 2025, that there is a legal review being undertaken to assess whether retroactive damages can be assessed. So I'm assuming then the first week of the new year, we are going to get an update from you all about what this legal review has entailed and what the decision has been made. I just have 2 more questions. To finish up, the first question to finish up this line, do you have any idea from the previous contract how much we paid for services that we ultimately did not receive?
We'll go back and get you. We'll go back and get you that information.
Based on the audits that we've done, I see you looking a little perplexed, but if we're hearing that, again, based on OLA's response that we didn't do.
That's what I was trying to just understand is, are you referring to things that LD potentially could have been assessed for? Is that, I'm just trying to understand what the framework of the question is.
Yeah, I mean, that would be one figure just as you did, I think that's the right way to frame it.
Okay.
And then the last question that I'll ask, I think just goes to the future. I mean, I'm glad to hear your assessment that you were going to hold Centurion, the new contractor, to the fullest extent of the agreement. But I think just taking a step back, and I don't think I'm speaking out of turn here because a simple Google search of Centurion will pull up pretty egregious problems that they've had, that they've been dropped by numerous other states, including our neighbor to the north in Delaware. They've had lawsuits filed by numerous inmates. They've had problems in Arizona. And again, that was just a simple Google search that I did last night after doing a little bit of research on the procurement. So I know that you're working within a framework here. All of these companies seem like pretty terrible actors, I will just say that, right? And this is ultimately what happens when you privatize health insurance for the most vulnerable population that we have in the state. So I guess my question is, because this is something that I haven't been able to reconcile, and I'm hoping you're gonna give me a good answer on this. So we have some of the most brilliant medical minds in the world who reside in Maryland, between Hopkins, between between all of our research institutions. And so what I don't understand is, again, to Mr. Tannen's comment, fool me once, shame on me, fool me twice, 3 times. When you look at the audit findings, and I'm not putting this on you because many of these were before your leadership positions, this is a problem, right? Again, and this to me goes back to the fundamental problem that we are privatizing health insurance from our most vulnerable population. What I don't understand is, given the brain trust that we have here, I have seen no hints or inclinations around innovation of maybe we should bring this back in-house. Maybe we should take the profit motive out of this. Maybe we should not be contracting, frankly, with, I mean, all of our options are bad, right? These companies, it's rope-a-dope. They close, they reincorporate, they go bankrupt, they reincorporate, and we continue to contract with companies that have terrible, I mean, again, right? We have a public institution here that could do this with a little bit of creativity. These staff don't just exist in thin air, right? The private company is hiring a workforce in our state that could also be brought in-house. So what is your comment on that? Why aren't we doing anything innovative? It seems like we're literally doing the same thing, nibbling around the edges, saying we're going to enforce the contract better when the entire premise of this contract seems flawed.
So I will say to you that on this most recent procurement, we did do that because in reviewing procurements from other states around the country, we saw how they had linked up with their university systems, with their other hospitals within their areas to manage that at that time. Unfortunately, it was not the decision of the secretary that sat here before to go in that decision, because those recommendations were made as we reviewed. We said there are actually states out here that actually use their university system to control their health care, and they don't subcontract out to a private vendor. Some have gone into that. Some of the larger states, part of Texas actually does that. So we did, when I tell you we reviewed numerous procurements throughout the country. So we saw everything from privatization to state-run medical facilities, but that was not the decision at that time for the secretary that sat here.
Right, but what about the new contract? We just signed.
Remember, he came in as we were working, he was here as we were working on that new contract. It's just that it wasn't awarded until after.
So you mean to tell me, as your current role as secretary, you essentially don't agree with hiring Centurion?
I didn't say I don't agree. I said we explored other opportunities.
Right, but that seems like the ultimate put off. So as the secretary, you could have easily said, we're gonna pause this. We're not going down this road with Centurion. We are going to figure something else out. We're going to figure out an interim solution. And you're saying your hands were completely tied?
Had we paused, we had already paused it once and extended that care with Yes Care. And everybody in here knows the concerns with Yes Care. That original contract was over within December. We paused it until January so that we could continue to investigate and review what those best practices were. So we made a decision that we felt was in the best interest of currently our incarcerated individuals by bringing Centurion on when we looked at the abilities that they had.
So we've now locked ourselves in to a 5-year contract with Centurion, even though you think we should have gone a different direction.
I didn't say I thought we should go a different direction. Let me say that again for the record. I said that we explored all opportunities and looked at other state contracts that had just what you asked, where other states used their healthcare providers in their communities to do that. We did look at that. We have looked at that.
I'm still completely befuddled because you made it seem like that is a direction that you were interested in going in, but
I never did that, and I will be clear for the record that I did not say that.
So you're not interested in using our public facilities or figuring out how to bring this in-house and remove it again?
I'm going to answer you one last time. As part of the review and I was not on the evaluation committee, but I did receive the documents that the previous secretary gave us from we got them, ACA sent us documents, CLA sent us documents from other states directly, we got documents. So we were able to review how healthcare was provided. That was part of the review.
So point blank, do you believe this should be brought in-house with our public institutions in this state, or do you believe that a continued private for-profit contract is the way that we should be going?
That's something I would need to do further research on.
All right, that's really unacceptable, but thank you for your answers. And I think
We'll go to Delegate Moon, and then Senator Hedelman, Delegate Harrison, Senator Corderman.
Thank you, Mr. Chair. So I just really want to be specific about whether the problem has been addressed. And the problem, as I'm looking at it, is specific to the staffing ratios again. So if the numbers in the chart we are looking at are accurate from the last procurement, it seems to indicate there are 19 psychiatrists for 18,000 population and 21 counselors for an 18,000 population. Are the numbers in the current procurement, what are the numbers in the current procurement for mental health professionals and regular medical services?
So I think regarding the specifics of the different labor categories, we will have to provide that to you. I don't have that information off the top of my head. But having said that, regarding the previous contract versus this new contract, one of the things that we did do is increase the overall staffing levels. I know you were mentioning the ratios earlier in your initial comments. Some back of napkin math, we have approximately, I think it's 1,294 staffing positions across both the pretrial and DOC under the new contract for a population of around 18,500 people. That's a ratio of 14.25 per II. So we have increased the staffing under the new contract. And again, I think that coupled with some of the measures that we've taken related to the 75 percentile on salary, as well as a new vendor with new expectations and new monitoring, the expectation from the department with this new contract is that staffing levels will be in an acceptable level, that we will have enough people to fully rectify the needs and provide for the needs of the population within our care.
Okay, so just so I understand this very clearly, 1,200 is the approximate number of total health professionals for the 18,000.
1,300 within the contract.
1,300 are contracted for. So theoretically, if they actually show up, got hired and show up for work, there's 1,300 medical professionals. And again, if I'm looking at this, there's some split of this. It's probably going to be at least 2 to 1 are going to be medical professionals versus mental health professionals, right? So
we're happy to provide that information with more specifics, you know.
I would love to see specifics because again, when you're coming from last 2 years ago, there were 19 psychiatrists for 18,000 people and 21 counselors for those 18,000 people. Again, if those numbers are correct, it's, you know, I think we have to be following this. And I guess the other question I have then is, I'm a little nervous about some of your statements that you don't think the staffing ratios should be so specific. I would agree with that so long as they hit some threshold of adequacy. But again, when I'm looking at what the audit says, that some facilities have 500 to 1 and 12 to 1, you know, that's a pretty big range. And then when you're looking at the floor 2 years ago was a half a dozen mental health people for 18,000 people, I would like a little bit more assurance, not just that the current procurement is adequately staffing and exactly what those numbers are, but that our procurement and monitoring systems for the contract actually are very specifically geared towards the staffing levels. I just want to, I mean, this is sort of all over the audit findings, but again, this is the contract. It's a staffing contract, right? So it seems strange to resist the concept of there being some known fixed staffing ratios that we can expect in the procurement. Are they in the current procurement?
As a part of the current procurement process that I never got a chance to finish answering the question, For example, you're talking about the mental health side of the house. Staff were increased for the mental health in the new contract because of the acuity of the patients at Producton, for example. Staffing was increased for the law that was passed for the medicated-assisted treatment because that's going to give the Department, it has started to give the Department of Corrections an influx of individuals who are sentenced in the county and come to the Division of Correction who are addicted to substances and have to be continued on those 3 FDA medications. So it was those kind of conversations as a part of the whole assessment of these 3 contracts that we looked at, that my mental health doctor sitting back there, the medical doctor sitting back there, all were a part because it's their professional evaluations that fed into what those numbers should look like. Additionally,
What are those numbers? What should it look like?
We don't have that in front of us right now for the, we said we would show you.
Can you assure us that it's not 20
contract.
people? That it's, that the numbers into, are we into 3 digits with mental health professionals?
Well, sir, with all due respect, I think it's also important to point out that not every incarcerated individual has a mental health problem.
That's not true. The DOJ,
I said not every incarcerated
it's like 60 or 70%,
It's
nationally
not
and in Maryland.
Nationally,
And in Maryland.
we can quote different statistics, but 60%.
What's your estimate? It's going to be about 2/3, at least half. Diagnosable DSM, I would guess, is going to be, I don't know, you're at least 30, 40%. I mean,
I was
the
going to
frontline
say
staff would say 60%.
30%-ish will probably be the figure that I would quote you because that's going to
I've
still
never heard
fall
a
in
number
line.
that low.
Still
That's
going to
a
fall in
very low
line with
number.
those who are addicted to substances. And it can depend on where they're at, whether they're in the psychiatric facility or Patuxent.
30% of 18,000 is 6,000. Do we have mental health staff to service 6,000 people, more than 20?
Are you referring to the total
Now,
contract?
I mean now, just.
But see,
so-
you're quoting the previous contract, and I don't know the numbers off the top of my head, what's in the new contract, but like I said.
But it seems to me that this is the heart of the contract, is the staffing, and I guess this was the point of the audit. So I appreciate that you have to get back to me on the numbers, but it seems to me the point of the audit might not be sinking in if in fact basic numbers like how many doctors and nurses are currently working in the system is an unknown number. It's not giving me much confidence that my concern that we are minimally staffing these to not get sued again and to not have people committing suicide or whatever. And I know the drugs all got stolen out of the facility, so they're not getting drug treatment either. I mean, I don't think that's a part of this audit, but there's other things that we could talk about. So I guess just so I leave here, because you're probably not going to hear from me again unless it's a bill. So I would like to leave here knowing that we don't have a situation of 20,000 for 6,000 to 18,000 mentally ill people.
So I think what we'd like to do, if you're amenable to it, is, again, we can quote you off the top of our head the total number of staffing, but when you're looking at a more detailed analysis related to all of the different medical professional positions, what we would like to be able to do is provide you that document, because again, I think the department's expectation when creating a procurement, when putting that out for public solicitation is, this is what our determination of the needs are. Right? And, to the audit's point, under the previous
Nobody
contract.
can say what the needs are. I find this crazy. We got sued, we have a new procurement, and no one still can tell me what the standard is for staffing? This is very strange. Staffing seems like in corrections has been in the news every day. No one has an idea what the proper staffing model is for this in light of the lawsuits in the news. Thank you.
All right, thank you. Let's try to be brief with the questions to the members so that we can try to get to as many folks. I know we have a lot of questions here. Senator Hedelman, followed by Delegate Harrison.
Thank you, Mr. Chairman, and thank you, Madam Secretary, and folks for being here. Appreciate it. I'm going to follow up on this line of questioning. The 18,000 people that we're talking about, 18,547 to be exact, is an increase in the number of people who are incarcerated from when the audit took place. In addition to the 44,000 people plus that you're talking about under parole and probation. And I'm assuming that you're providing health care to them too. Is that correct?
some of them do have continuity.
So we're
care.
talking over 60,000 people, aren't we, under your care with these same staffing levels? Is that right, or am I missing something? Is there a different core of people that is focused on parole and probation?
So parole and probation does have a nurse for those. There are only a portion of parole and probation, namely it's the sex offender populations, those that have to come in frequently. And then what we do for the other individuals, there's a continuity of care that occurs when they're released. And we connect them to a community provider so that that community provider continues their care. We do, if they are on psychotropic medications, we do provide them the 90 days of support for psychotropic meds. If they're on regular meds, we give them the 30 days of support, and then they're provided to a provider in the community if they are no longer under our supervision. If they are under our supervision and there is a need for care, and I guess Dr. Jerkins, my chief medical provider is in the back, can actually correct me if I'm wrong, but there is a duty of care that they do receive, a referral that they receive, so that they can continue to get the care that they need.
Right, but these 44,000 people can be under your care for a night, 2 nights, or months, is that correct?
Depending on the nature of their illness.
Not their
The
offense.
Their
Their
offense, I'm
offense,
sorry,
yeah.
offense.
So these numbers are even more dramatic if we're going from 18,000 to over 60 in terms of ratio. And I understand that's not entirely fair, because again, some of those people are just going to be there a couple of nights, but some of them are going to be there for months. And we need to be providing these same kinds of services to the entire population. I mean, is that correct, or am I off here?
So, and DSO just reminded me that we do have a separate contract for our home detention and our sex offender population that namely are the ones that we see needing the more continuity of care.
Right, but those, we're not having these healthcare practitioners that are articulated here going out to people's homes who are on home detention, right?
No.
So, and then that's, I'm assuming, is that a small population of the 44,000? Or how many of the 44,000 roughly are behind bars?
Of the 44,000 are not incarcerated. They're in the community.
They're out in the community.
Yes, ma'am, right. The 18,000 is what is behind
bars, totally. Oh, okay. So can you tell us the difference between the contract, the prior contract, and this contract in terms of staffing? And is there a number that you can give us? You said that there was an increase in staffing, and obviously I'm not going to hold you to it, but are we talking, what scale are we talking about?
Yeah, so I can tell you the previous contract from me working on it, the full-time, the FTEs for that contract was about 845, and we're up to about 1,294 is what the current one is.
Okay.
And we're
50% increase.
So a 50% increase.
Approximately.
Okay.
And again, we can provide you those attachment R's so that you can see the specific breakdowns of both.
Okay. I'm going to also go back. I think one of the co-chairs expressed some frustration at kind of looking at the system. Like, this is, and I think the audit got to this somewhat too, that the system, that this is a systemic problem. I mean, would you agree that these are systemic issues, and that having a vision to be able to look at kind of outside the system, what is it, how can we make the system work better? There are people in the system who are trying to execute the different policies and processes, but these issues go back to 2007 and probably long before that. So it does require, in my opinion, some kind of step back to look at, okay, how can we make this system look better, whether it is trying to get others in the community and their expertise to be able to look at it, to envision how it could be better. And I guess, did you sign the contract for the new?
I did.
You did sign the contract for the new, and that this is a 5-year contract, right?
That is correct.
And we now have 6 to 7 people, you said, that are fully staffing a new audit unit to make sure that the people who need these different assessments and need the care are actually going to get it. Is
So
that-
aside from the creation of the audit unit that now comes under Assistant Secretary Brooks, we also have our ACOMs that are out in each of our facilities. So they are the administrative managers that work for the state, that independently oversee those aspects of the contract related to the facility that they're assigned to. They are the ones that make sure that timeframes are in place and are being met and filter information back to the audit team at headquarters so that we can apply liquidated damages where appropriate. But they are on site every day, so they are dealing with the contractor. I will also tell you that this contractor has brought in a lot of high-level individuals. Their director of medical services, he is from Johns Hopkins University, and he has helped us create a very viable and strong relationship with Johns Hopkins. So there's a lot of consultation going on between that. So this new contract, we are working to better things, and we continuously and progressively look at how we can and make improvements.
Do you have any idea, because I have heard that there are many of the same staff in place from the prior contract, right? Just because there's a new company that comes in doesn't mean they're clearing house and bringing on all new staff. So we're virtually talking about the same people on the ground doing the same work. Is that correct?
Thank you for answering that question. One of the things that I required, and I had the direct communication with the Vice President of Centurion, was that they revet everyone that was under the current contract, and that if they did not meet the credentialing and vetting to meet the job criteria, they were let go. Many individuals were let go, have been let go, and Centurion is currently doing a new recruitment. They have a recruitment, it may be today or tomorrow. They are doing a big recruitment that they advertise in the Columbia, at a hotel in Columbia, just to hire staffing for DPSCS because of the number of staff they had to let go. And they are continuously monitoring staff that they may have kept, because they have also allowed some individuals to go through vetting, found credentialing was good, and then we found their performance was not good, and they've let those individuals go as well. So they are still beefing up their staffing at this time because they did not keep on everybody, as you traditionally see when a contract changes.
Okay, one final question, if I could. What is it within your office that you have changed or will change going forward to make sure that you have the oversight and accountability that we didn't have?
Thank you for that question. So one of the things that I did bring Mr. Brooks back as the new Assistant Secretary for Programs, Treatment, and Reentry Services. Those of you that don't know him, he is a stickler for accountability. I know him from my past history in pretrial when he was the compliance director, and he was previously the director of the MCC Audit, so he knows the standards. Mr. Brooks and I have a bi-weekly meeting so that I'm updated, as well as a weekly document that comes to me so that if there are questions or concerns, it's immediately elevated to me. I've established a great communication with Vice President of Centurion, Ms. Maria Evile. We talk to each other 2-3 times a week so that I am on point as to what's going on and what is being done to correct it. So we've established open communications, which is something that I did not see in the previous contract. I did not in the previous contract have the ability to communicate with the vice president or the president of those companies so that they could then filter down and enforce what their staff was doing to make sure. So we're having those communications now.
Okay, thank you for that. I would also encourage you, with all due respect to having a good relationship with the company, their interest is the contract, right? And the funding and the reimbursement and the money that they're getting from the contract. I would urge you to look inward and to talk to the people inside who are the ones who are getting or supposedly getting or should be getting the health care that is required. I mean, I'm sure I'm not different from other of my colleagues here who regularly hear from people on the inside who are very concerned, and it's an aging population, as you know, who have more complex healthcare needs as they age behind bars. And so I would urge you to find some kind of regular systemic way of hearing from the people inside about what their experiences on the ground are.
So one of the things that we've done is through our administrative remedy program, which the incarcerated individuals have a chance to send their information because they need care. There was a challenge with care. We recently did an audit of the administrative remedy. And full transparency, the only concerns that we had were at JCI, which was one of our larger facilities, where we're seeing there was a delay in responding to some of the time. All other facilities were actually compliant and making sure that they were getting the care that we need. So administrative remedy is another tool that we use to ensure that the incarcerated population is getting the care that they need when they send us that information. They are also now having, our wardens are having what's called MAC meetings, and they're having those meetings monthly. So they're having the meetings with the staff that are on site for the contractor because of concerns that custody is hearing from the inmate population. And so there's a chance at that point for the assistant warden who's over that program to actually do some troubleshooting and corrective action during those MAC meetings as well.
Thank you. Thank you, Mr. Chairman.
Thank you, and I think that my questions will be relatively quick. Actually, the first one is just a clarification to make sure that I understood what you were saying. As we talked about the contract, you said that when you were looking at the contractor's references, that the staffing or performance termination did not directly impact DCSPS. Did I misunderstand that? Can you just correct me?
Yeah, so within the actual reference checks, there were 2 terminations that were identified. One was a no-fault termination, and that's one of the things that you'll see in different states because different states have different mandatory contract terms, right? In the state of Maryland, whenever you sign a contract, there are 2 methods for termination, default or convenience, both solely within the authority of the state of Maryland. In other states, they do have, bilateral terminations where either party can cancel a contract. A no-fault termination was identified, and again, when you look at a no-fault termination, both parties mutually agreeing to stop a contract, then that's not something within the procurement process that you would necessarily identify as a red flag because there are multiple different elements associated with that for why that determination might have been made. Right? And I think the reference check ultimately when they get graded out and when the evaluation committee, and please keep in mind that none of us here were on that evaluation committee, so what we're doing is we're relying on notes and the documentation that we're able to see, and the same things were provided to the Office of Legislative Audits. The other one was really a result of a inability to contract with a third party. So rather than, in this scenario, the vendor contracting with a government or state entity, they were unable to come to an agreement with a third party that contracted with, I think it was the state of Virginia, if I'm remembering correctly, but please don't quote me on that state. And so again, when you look at something like that, that opens up, you're functionally looking at a subcontractor agreement versus something that in our scenario within the procurement process, we're looking for has Massachusetts, has Texas said, you're not good at your job, I'm killing your contract. That's a huge red flag. If parties mutually agree to terminate a contract, there's myriad reasons why something like that could occur. So it wouldn't necessarily rise to the level of we're obviously going to do the reference check, that's part of the procurement process. But it wouldn't necessarily be we cannot award because of this. I hope that answers your question.
Yeah, that's fine. I was writing notes and maybe didn't get it all.
I had that too.
The next question actually goes back to some issues that we have heard constantly here about information technology. And so at one point, Madam Secretary, you mentioned there was a question that was asked, and I think it may have been related to some sort of evaluation, and you said that it could have been that your systems were down. And so my question is, how often are your systems down, and how often do they go down? How long are they down? What is your relationship? What is your IT situation and relationship with Do It Here? And then my follow-up question to that has to go back to the issue with payroll. Now, we already know that we don't have much money here in the state, so we can't afford to be paying people that are no longer employed by the state. So if you can address that, I think the audit said that there was only one person who was in charge of ensuring that termination was seen all the way through. And we had one individual and they were failing in some areas. And what are you doing to fix that? And then the final question is, you mentioned that you were in agreement with some of the findings of the audit, that you had already established some new practices, and that you were in disagreement with other findings. When will this committee know and hear back from you on what you're doing to address the questions and the concerns that we're hearing? Because we can't wait for 5 years.
Okay, thank you for your questions. I'll kind of do them a little out of order. To your last question, we've already created a corrective action plan. I'm happy to share that with the committee, so we can get that to you within later today. We did do a corrective action plan for every item that is associated with the audit. As far as the intakes and ITCD, we are a little unique that we do have our own information technology department. We don't have to go to do it for everything because of the many systems that we have and the interoperability between those systems. So we have what's called an offender case management system, and that system allows us to track every individual from the time they come in the door to the time they leave from one of our facilities through their supervision with the Division of Parole and Probation. We are able to, when they immediately, if you've ever been to Central Booking, which is the intake facility.
Thankfully, I have not. Don't plan to.
As a visitor, the first thing that you have to do in order to get into that facility is to go through a successful medical screening. It's called an IMMS, the Inmate Medical and Mental Health Screening. There is a nurse practitioner or a PA at the door where you go through that screening that determines your eligibility to sustain 24 hours before you see a court commissioner. If they don't feel as though you're able to do that, then they release you back to the police, and the police has to take you to an outside hospital. If you are able to sustain that and you are accepted into the facility, then what they begin to do is to do a diagnosis to see what your comorbidities are, what your acuity is, so that they can begin to order medications and provide you updates for what clinics you'll be going to should you get a bail and you stay with us. Once you receive that bail, you are seen by medical and mental health again to ensure you during that IMMS that I spoke of, there is a series of about 25 questions. Those questions range from anything from do you have high blood pressure, do you have diabetes, to are you suicidal? Are you feeling suicidal? Are you feeling homicidal? Have you ever had suicidal ideations or tendencies? All of that's asked during that, and an assessment is done and the referral is made. So you are seen by medical or mental health based on the assessments that are made by those practitioners. And then on the DOC side, when you come in as a sentenced individual, if you came from Baltimore City because we supervise you, not only is that record transferred so that they can see that while you were under our care, you were already on psychotropic medications, but an evaluation within 7 days, a full physical to include a mental health screening has to be done for you. The system does go down periodically. It is not a consistent thing. But oftentimes the inconvenience is that when the system goes down, it's at our peak hours. And for Central Booking, our peak hours are 3 p.m. to midnight, Tuesday through Saturday. That's when we see the most people come in. And we service about 1,500 incarcerated individuals a month down there. So if the system goes down, medical reverts to a paper a paper IMMS, where they're writing that information down and they're literally taking it and filing it in an inmate chart, versus it's in the system, it's transferable data from the IMMS data to what we call EPHR, which is our the medical record for our incarcerated individuals. So that's where I suspect that 500 and some may be, because routinely we do this every day. I know it for a fact because I was not only the warden at Central Booking and oversaw that population, but when MRDCC was the DOC intake, I was the warden there. And I know that that occurs. Every medical intake is being done. So that's where we are there. And Joe is going to answer the last question.
Yeah, sorry, you were asking about payroll?
The terminations
Yeah.
and the payout of individuals who should not have received.
Yeah. So, I mean, I think one, just for context, right, is you have to remember that we're a very large agency across, how many, 18 facilities? Right, we're huge and across the place. And I think what the audit has identified in that in the past, this was very manual to a certain extent, right? Being terminated or resigning, any of those things that are formal workday determinations as a term, right? Any of those things require a resignation letter, some sort of a paper document or an email in order to make its way up to HR that then makes its way into payroll. One of the things that the department has done is streamline that process so it's no longer strictly relying on, hey, my name's Bob and I'm going to send my resignation letter to my supervisor who then has to send it to the one person over in HR, and God forbid they're not on vacation for a week. Right, we've created a smart sheet system that is accessible to the entire department, that when those actions occur, get entered into and they're monitored by multiple staff within HR and within payroll to ensure that these processes do get accounted for in a timely and accurate manner. Furthermore, within that, on the payroll side, we are working in conjunction with DBM, receiving reports from them to make sure that if there are any potential inconsistencies or when they are identifying that these terminations, that payroll is able to go back and make sure that folks aren't getting paid if they shouldn't be getting paid. And point blank, if it has happened, if there's a 2 or 3 day turnaround, that we're promptly able to go into the recovery process where the payroll department is able to go through our accounts receivable and request payment back. And if after a 90 or 120 days, forgive me, I can't remember the exact date, if during that period recompense has not been provided, it is then referred to central collections.
So just to make it very plain, you don't have one person anymore who's doing this. It is an electronic system that has been set up with various checks and balances, so that so that the system, I guess, catches if a person has been terminated and a check has been issued. If that has happened, then there is a mechanism to go and automatically reclaim or request repayment of what was sent in error.
Yeah, and there are multiple different things that can be done, right? Sometimes it's, hey, I need you to write me a check for $1,000, right? It could also be, hey, you're 2 pay periods away from getting a payout, because as you know, right, annual leave gets paid out upon separation from the state. It's, hey, if you're due $2,000 in annual leave, but you actually are owe us $1,000, we're going to net it out and make sure that we utilize the final payout as that avenue in order to get the money. Both on the ground and supervisory level individuals who are monitoring this holistic process to ensure that terminations are appropriately handled and entered into the system, so that these instances are minimized.
Okay, so then the committee can get back, the committee will get from you then what your plan of action, your corrective plan of action is. The committee can expect that from you. The corrective plan of action, what you've already done, what you plan to do. We already have in place a way to ensure that individuals are not being paid if they've if they've tended their termination, whatever. And if so, then we can get repayment for that. And then
your OIT is separate and apart. Okay, those were my questions. Thank you. And if I can add for you, I think what DSA left out is the staff in that unit. There is now a great accountability factor there because the supervisor has changed. The leaders that were there have changed. There's even a new director of HR that's only been with us maybe a month now. So we have changed leadership there because we did see the lack of accountability, and we needed people in place that we knew were going to implement the new procedures and make them effective.
So to the members, I'm going to ask that we take a pause with the Department of Public Safety because Secretary Herrera Scott has to meet with the Senate President at 1. So if we could do a switch to her, and we'll come back to Senator Quarterman. I know Delegate Arntz also has a question. If you can come back at 1 o'clock when we expect them to wrap up, we'll have you come back before us.
Thank you.
All right. Welcome, Madam Secretary. You can go ahead and begin. We have your presentation drawn up here.
Good afternoon, everyone. Do I have a clicker, or do you do the clicker? I'm rusty. I'm sorry. I forgot. Okay. If we can go to the next slide. So this is a little agenda that we prepared. I'm sorry, I'm Laura Herrera Scott. I'm really rusty, as you can see. Laura Herrera Scott, Secretary of Health. With me is Emily Brandenburg, Chief Financial Officer of the department, as well as Fred Doggett, who oversees our audit functions for the department. A brief agenda of what we're going to be going over. Oh. Okay. Is that better? Okay. No? I'll use my outside voice. Is that better? Okay. Unfortunately, Ryan Moran, who was also going to be here for Medicaid, had a conflict today, so I'll be also doing the Medicaid piece. But here's an overview of what we'll be talking about today, and I'm assuming you'll ask questions as we go. Okay. For the end. Okay. Next slide. So OLA conducted 16 separate MDH reviews. Most recent report contains 93 findings, including 31 repeat findings, 3 Medicaid audits, medical care programs administrations, MCPA managed care programs, and pharmacy services. 9 of the 31 new repeat findings, and the remainder are within the following administrations. 4 repeat findings in the Developmental Disabilities Administration, 3 repeat findings in Regulatory Services, 2 repeat findings in the Office of the Secretary, State Psychiatric Hospital Centers, Behavioral Health Administrative Services Organization, and 1 repeat finding in the Prevention and Health Promotion Administration. Next slide. This is the overall progress on the repeat findings. You can see in Medicaid, 7 of 13 are fully addressed. Finding 4, MCPA had not established adequate oversight to ensure that all CFC program recipients receive personal assistance services in accordance with their plans of services. And finding 5, MCPA did not monitor the utilization control agent contractor to ensure continued state reviews of Medicaid recipients receiving services from nursing facilities were performed timely. For Medicaid MCOs, finding 2, MCPA did not have comprehensive procedures to ensure 10 that ineligible costs reported by the MCOs were excluded from the capitation rate calculation, and finding 3, MCPA did not have an effective process to identify capitation payments to MCOs for incarcerated individuals, resulting in approximately $14 million in improper payments during fiscal years 2019 to 22. For pharmacy services, there were 3 incompletes. These are the complete ones, I'm sorry, the ones that were fully addressed. And that was Department of Health did not have procedures to ensure that prescribing providers were licensed prior to approving pharmacy claims for payment. Finding 3, MDH did not audit 3 of the 4 fee-for-service program pharmacy claims. And then finding 4, MDH did not ensure the drug manufacturers provided timely and proper drug rebate programs for the Maryland AIDS Drug Assistance Program. For DDA, 1 of 4 was fully addressed, and that was finding 6. Fiscal management services contracts procured in 2006 were not comprehensive, properly approved, and adequately monitored. As a result, DDA did not recover unspent funds totaling $3.2 million and obtained federal reimbursements totaling $8.8 million. Regulatory services, 3 out of 3 are still in progress. On the Office of the Secretary, 2 of the 2 are fully addressed, which was finding 7. MDH did not always comply with state procurement regulations when procuring goods and services via sole source and emergency contracts. And finding 14, MDH had not established adequate controls to ensure the biweekly payroll payments, leave balances, and timesheets. For BHA and ASO, 2 of those 2 are still in progress, and the other 5 of 5 are still in progress. So a total of 10 of the 31 have been fully addressed. Next slide. Next slide. In the Office of the Secretary, overall findings were issued in 2023, including 17 findings with 2 repeats. The repeat findings relate to 1, compliance with state procurement requirements, which we just talked about, especially for sole source and emergency contracts, and 2, controls to ensure the propriety of biweekly payroll payments, which we just talked about. In the Joint Chairman's Report issue in September 2024, and we reported corrective actions for the repeat findings, as well as most of the remaining findings were complete. Next slide. In the Office of Finance, I'll turn it over to you for this one, or is this one me? Okay. We have engaged an external accounting firm as recommended by OLA to assist with the corrective actions related to findings 1 through 5. The contract was initiated in August of last year and extended through January of 2024, recognizing the continued need for services to fully respond to the findings. In collaboration with the external accounting firm, we have successfully completed numerous reconciliations, standardized and documented existing processes, and developed enhanced procedures. These initiatives, once fully implemented, are designed to address the identified financial accounting issues and help us prevent similar findings in the future. And I'll now turn it over to Emily Brandenburg to go into detail on what we've been working with our external accounting firm and what we've accomplished to date. Next slide.
Thank you, Secretary. MDH, in partnership with our contracted external accounting consulting firm, we have made tremendous progress over the last year to develop and perform reconciliations, standardize and document processes, and create efficiencies through automated workbooks. 17 reconciliations have been developed and performed to date, and they encompass years fiscal year 2018 to fiscal year 2024. These reconciliations match the transactions from MMIS and FEMAS to make sure that expenditures have been recorded properly, revenue has been allocated from the clearing account correctly, and that federal revenues have been received and requested. To date, we reviewed 37 million transactions, and we reviewed related to Medicaid and DDA reconciliations. It resulted in $1.5 billion in total variances identified, which allowed MDH to allocate revenue and expenditures and confirm all available federal funds were received or requested. As a result of these reconciliations and additional cleanup activity, we've been able to close 874 lines on the Schedule G and reduce the receivable balance by about $1/3 billion. For Medicaid and DDA alone, we've been able to close 431 lines and reduce the Schedule G balance from a $1.8 billion receivable to a balance of a $1.2 billion surplus. The swing from a receivable to a payable balance for Medicaid and DDA is due to a variety of factors, primarily revenue to expenditure matching, but also allocation of revenue from the clearing account and allocation of revenue to pass-through entities. We've also developed 16 Medicaid and 4 DDA comprehensive business process documents and 2 automated workbooks, which enhance operational efficiency, quality control, and team collaboration by standardizing business processes documents and automating key repetitive tasks. These initiatives have significantly reduced labor hours, minimized errors, and enable stakeholders to focus on the value-driven analysis, increasing productivity and efficiency. These documented procedures ensure that if we experience staff turnover, there is no single point of failure. We have our best practices and procedures documented and transferable. Upcoming activities as we continue our work with our external accounting firm is to continue to review Schedule G analysis. We're working on our clearing accounts now, reviewing and reconciling. I'm continuing to implement workbook automations where appropriate, and reconciliations with DDA and BHA, behavioral health. Next slide, please. Thank you. We wanted to take an opportunity to crosswalk the audit findings to the reconciliations and processes that I just discussed on the previous slide, and to demonstrate the work has been accomplished towards remediating the audit findings and the magnitude of the reconciliations that have been implemented. We're not only doing analysis to clean up our records and make corrections to allocations, we are creating reconciliations, implementing processes to make sure we are performing activities consistently and effectively, and have appropriate review and controls that we are reconciling timely so we can prevent these concerns from arising in the future. Thank you. Next slide.
Is this one? So other findings were related to procurement. Findings 6 and 7 relate to procurement disbursements are listed here. I want to ensure the committees that addressing these findings is one of our top priorities. We have recently rolled out a series of trainings to staff based on the recommendations that came out of the internal review of the COVID emergency contract. So this work continues. Next slide. For Medicaid, there were 15 findings, including 10 repeat findings. Primary 8 findings with 6 repeats. I've talked a little bit about each of these, including the third-party liability, payments to incarcerated or deceased recipients, oversight regarding community first choice recipients, monitoring utilization control agent, validation of claims, adults of medical daycare and support planners. For MCOs, there were 4 findings, 2 repeats, including ineligible costs reported by MCOs for capitation and identifying capitation payments to MCOs for incarcerated individuals. And for pharmacy, there were 3 findings, 2 repeats, including ensuring prescribing providers were licensed prior to claims payments, auditing fee-for-service pharmacy claims. For all of these things, we have a very detailed spreadsheet that we work with Fred's team to hold the Medicaid team accountable. And what are the meetings, biweekly? Yes. Where we meet biweekly and we're going through each of the findings with a plan in place to address each of the findings. Next slide. On Medicaid, primary, pharmacy, and MCO, again, on primary, 4 of 8 are completed with 3 of 6 repeated findings completed. For MCO, 2 of 4 have completed with 1 or 2 repeat findings completed. Pharmacy, 3 of 3. completed with 2 of 2 repeat findings completed, and overall 9 of 15 completed with 6 of the 10 repeat findings completed. And here are the highlights of the progress. On primary, working with the contractor to support implementation of third-party liability and have testing in progress with the MCOs. Finalized agreement with new utilization control agent to support audits related to ventilator care claims by nursing homes. We've begun audits of supports planning programs and medical daycare programs for first time in 5 years with clear policies and protocols. We've established new MOU with the local health departments for oversight of nurse monitoring for Medicaid participants and Community First Choice program. And we've had successful implementation of ensuring prescribing providers were licensed prior to claims payment on 7/1/2024. And lastly, on DDA, overall findings were issued in 2022 and includes 8 findings, including 4 repeats. Repeat findings include ensuring that coordination of community services agencies completed annual consumer service plans and conducted monitoring visits. 2, ensuring appropriateness of amounts invoiced by CCS agencies, which are the coordination of community services. 3, conducting required audits of providers, and 4, issues with the fiscal management service contracts. As of May 2024, OLA audited and MDH concurred that work on corrective actions for 3 of the 4 repeats was ongoing. OLA is currently wrapping up its audit of DDA. Next. And then we did want to call out that on October of this year, DDA released a self-directed services policy and manual and associated forms. And the policy itself is not new policy, but reflects consolidation and clarification to improve quality and accessibility for services. It's really aimed at reducing the processing delay and help ensure taxpayer-funded policies, services are delivered in accordance with state and federal guidance. And I'm sharing this because we've been asked a few times about recent changes in self-directed service policies, especially to address them prior to audit findings. And I just want to make it clear that these were independent to any of the OLA audit findings from 2022. And certainly in my role, I think of these are some of the things that we're doing now as part of my duty to ensure that these outstanding findings are brought to resolution. However, it's equally important that we are not solely reacting to audit findings, but also proactively adopting policies and procedures to prevent new audit issues in the future. And as I mentioned before, OLA is wrapping up an audit of DDA now, and we will continue to work with them proactively to identify issues. And with that, that concludes our formal remarks. I know I went through that very quickly, but wanted to make sure we had time to answer and address any questions you have.
All right, thank you, Madam Secretary. We have been in touch with the President's office. He did give us some wiggle room to 1:15, so we have a few minutes for questions to be able to get you over to meet with President Ferguson. Thank you for that update. I think for the benefit of the committee, this is in part to follow up on an audit that came out in October of 2023 that demonstrated potentially up to a loss of $1.4 billion to the state, billion with a B, to the state because of, I guess, financial accounting irregularities and being able to seek reimbursements from the federal government. Can you give us an exact number? You assured us a year ago that it was not going to be $1.4 billion in potential losses to the state, particularly given the current budget environment that the state's facing. You know, we're obviously very concerned about those types of impacts. What is the actual number at this point, a year later?
So I had mentioned it earlier in my remarks, but through a lot of the work that we've done, we're showing about a $1.2 billion surplus. Now we're still reconciling. I don't think that that's where this ends, but that's what we're seeing primarily in our clearing account, which is one of the next pieces that we're going to work with our external accounting firm to help reconcile and distribute the revenue appropriately.
So the surplus being there are prior services that you could request for reimbursement from the feds, or?
The surplus is federal revenue I have in a clearing account which needs to be allocated to the appropriate expenditures.
still in the clearing account.
Correct.
What is the balance in the clearing account at the end of this year?
About a billion, 1.2 billion.
Was it not one of the recommendations from OLA to have that clearing account balance be close to zero?
Absolutely. That's, as I was mentioning, that's what we're working on now. We've resolved the reconciliations with Medicaid. We're working through DDA as part of the DDA Medicaid work that we're doing. We're working through reconciling the clearing accounts as well.
So
But the clearing account still has $1 billion in it.
Correct.
So I want to just be clear, it's not, we can't look at the money in aggregate. We have to go line by line, which goes to the first bullet that was on the slide. Maybe we can go back to that slide. The team has gone through 37 million transactions. So that is all the puts and takes that come in and out of the accounts. So, which is the first bullet, and then 874 lines. So they're going line by line, reconciling all these accounts.
But you still have $1 billion in the clearing account that's still uncleared as of this point.
Unallocated.
Unallocated, yes. The good news, it's surplus now. So, and while we've been doing this work, again, we've been creating policies and procedures and standards. So it's not left to one individual to be doing this work, but whoever comes into this office to do this work moving forward, working with the accounting company to codify these processes so that there's a pathway moving forward to reconcile these accounts real time moving forward.
So in this letter that you sent to us, you said that you would, in working with this external accounting firm, have this finding corrected by June 30th of 2025. Is that when you expect this clearing account to be at zero?
That's our hope, working with them.
This has been pushed back already. I think last year you assured us that this would be accounted sooner, and the letter that just came out in September said that this would be now is being pushed back to June 30th of 2025.
So at the time when we testified before you, that was our best guess in partnership with the accounting company and based on what we were uncovering. And as we continued to uncover the data and go line by line, their best guess was that it was going to take longer than their first guess.
And is it still June 30th of 2025? Because that was what you said in September.
That's still the target date, correct?
Okay. You'd also, in this letter, said that there would be a development of a plan to be expected to be completed by December 31st of 2024, which is just a few weeks away. This is to ensure that all year-end revenue transactions are properly supported. How are we with the progress on that?
So can you repeat that, please?
Under finding 5 in the letter that you sent on September 13th, it said that additional work would be required to more fully analyze the automated script to determine the accuracy of the accrual, and the development of a plan is expected to be completed by December 31st of 2024. This is in relation to MDH's working to ensure that all year-end revenue transactions are properly supported.
So for that particular finding, that was finding 5, I think the piece that we're looking for is we want to pull the IT portion of the automated script and confirm that it's still running in the manner in which it should be running, and by all accounts it is, but we still wanted to pull that IT script just to confirm.
So have you developed a plan?
It's not written, but it can be written by the 31st.
I'd suggest to have it written. I think based on our prior experience with the earlier department, it wasn't documented, probably didn't happen.
Certainly.
Okay. Also in that finding, there was a recommendation from OLA to MDH to properly report any amounts determined to be uncollectible and to work with DBM to resolve any related deficits. This also has a completion date of June 30th, 2025. Is this in relation to the entire $1.4 billion that you're conducting follow-up on?
Yes, it was, but I didn't think at this point there were, I didn't,
To date,
there's nothing uncollected at this point. We're now in the surpluses that needs to be applied to the appropriate accounts, and that's the part we're doing now.
Okay, so since September, when you sent us this letter,
So we
there's
never
nothing
thought we
uncollected
lost
in
the money. Yeah, I know it wasn't in the right place, and the media posted as a loss of that money. We never thought we lost the money, it just wasn't applied to the appropriate accounts. So that is what we've been working on with the external accounting firm. But again, it is a very tedious process going line by line by line. So we don't think there's a deficit, but there's still this 1.2 that still has not been applied to the correct accounts that we're still working through.
so there's actually two directions that we're looking at here. One, to backwards go back and do this reconciliation, right?
Correct.
There's also a forward process
Correct.
to ensure that money that's coming in and transacting with
Correct.
the department doesn't continue to fall into a bucket that's not properly accounted for.
Right, so, because we went back to 29, we had to go back several years because several years, things were not being done. So it was not only cleaning up the back, but as we learned how that process was being done, also making sure codifying moving forward, how to ensure that those things get put into the right accounts moving forward.
So the retrospective should be completed hopefully by June 30th, 2025 per this letter. The prospective, are we ensuring, do we have a process in place currently to ensure that money that's coming into the department isn't just being dumped into a collections account that isn't fully accounted and reconciled to the appropriate invoices that they originated from?
Absolutely. Yes.
Okay, so we're not going to be digging ourselves out of a further hole prospectively moving forward. We're just digging ourselves out of the retrospective hole that we're in.
Which, as a reminder, we didn't create.
Even as we were doing these reconciliations, we made a conscious decision to work on 24, such that we closed 24 as clean as possible. And now going back to some of the prior years, exactly to your point, but the processes and reconciliations are in place such that we never find ourselves here again. We've cleaned lines from 1996, some longstanding receivables. So it's been an enormous lift.
Which is why we needed the extension to continue the retro, because we stopped the retro to make sure that 24 closeout was done based on the new process that we had in place. So we weren't then doing a retro of 24.
Okay. Just last question, then I'll go to Senator Hester. I guess over the last few years, have received repeated complaints about delays in approvals for self-directed care from recipients. You touched on some of the self-directed care elements here. How are these changes going to address the things that our constituents are concerned about?
So there have been the Self-Direction Act of 2022 allowed for new individual goods and services to be covered under that policy. And so under that policy, individuals or participants only had to attest for that services. And just a reminder, self-directed services are for habilitative and rehabilitative services. They're not for medical services. And so they only had to attest that those services are needed. And those requirements were not consistent with rules of CMS. So we are allowed to operate the DDA program as a waiver from CMS. So the federal government says you can operate this program differently from Medicaid because we give you permission to do that. And so we are now just going back to the requirements of CMS to document why those additional services that people are asking for are actually required for habilitative and rehabilitative services. So under the attestation, when we would question, there was a lot of back and forth, which was holding up the approval or denial. And now with the documentation on the front end, it is more work for the participant on the front end, but with the proper documentation, it's cleaner. We can give an approval or a denial. And then if it goes to a denial, then at least once it goes to OAH, they have the appropriate documentation to appeal the decision. So hopefully it'll make things smoother to make the decision real time and certainly on appeal.
Okay. Would urge just kind of keeping an eye out on that because we have been hearing concerns about those delays in approvals, so.
We do have service level agreements, and we are tracking, it's 20 business days, and we can certainly provide how long the SLAs are taken to make those decisions. And on last review of those SLAs, we are still within the timelines. Now, we do have cases that are exceeding that 20 business day SLA requirement, but the majority of them are going through.
Okay, thank you. Senator Hester.
Thank you, Mr. Chair, and thank you for your presentation, Secretary. I appreciate the due diligence that is put in. It's a big swing from like negative X number of billion of dollars to a surplus of 1.2 billion. I just wanted to figure out what exactly that 1.2 surplus balance is. Is it actually a surplus, or is it a reimbursement for expenditures?
It's a surplus. It's sitting in one of our clearing accounts. It needs to be allocated to the appropriate expenditures.
Could you please repeat and pull the mic forward? They can't hear you over
Oh,
there.
I'm so sorry. I'm so sorry. It's a surplus. It's federal revenue we've received that needs to be allocated to the appropriate expenditures.
So, but we have, I mean, the expenditures have to happen, right? It's not like we can take that surplus and use it against a $2.5 billion deficit in the overall budget we have right now, or can we apply that?
No, it belongs to expenditures. It's been previously drawn. It belongs to expenditures that are still sitting as a receivable on the Schedule G.
So just to be clear, surplus is expenditures that we've already had. This is money that's coming back in to be from the feds for
I think I would
reimbursement.
change the wording of this. It's not a good time to be talking about surpluses.
So we can change the wording, but so it's money accounted for as far as accounting principles go, but in this particular account, it looks like a surplus. But so to Emily's point, it just has to move to the place where it was already accounted for in the accounting.
So was it in the account? Like if we looked in the account, would we have seen the $1.2 billion just sitting there?
Previously, yes. Previously it was done on the aggregate. It was, when we looked at the Schedule G, we looked at all the revenues, all the expenditures, summed it up and said, what does the agency look like at the bottom line? And now moving forward, we're looking at this at the PCA level rather than at a much more intricate level. So previously we weren't allocating the revenue to the expenditures.
Okay.
So we're going through that process now.
So it's just like, I mean, it's kind of like sticker shock. And I just am curious. I mean, you've got these huge swings in billions of dollars. And, you know, when we were here before, Secretary, you know, I think you said that, you know, that, I don't know, the money wasn't gone or whatever. So it's just, it's super hard to really believe, you know, what's going on here. And I guess my question is, like, does OLA actually agree with these figures? Because they were the ones who, like, found the mistake to begin with, or the mistakes, you know, to begin with. Are you guys on the same page, like literally and figuratively at this point in time?
So I can't speak for OLA. I can tell you they just worked through for their closeout audit. We provided them supporting detail and documentation for Medicaid and the samples that they pulled. And then we had a meeting yesterday specifically about finding 2 and finding 3 to make sure they were comfortable with the reconciliation work, our reconciliation workbooks, and the process we're moving forward with. And we sent them over the workbooks in the most recent reconciliations this morning, actually. So
they haven't. So will we have an idea to hear from them later? Okay, thank you.
If you all can just confirm and commit, we obviously got this documentation yesterday, just that you're going to continue to work in any way that OLA needs so that OLA, DLS, the legislature feels like we're confident that everything's been reconciled appropriately.
we want the same, absolutely.
And just to Emily's point, the way we're doing it now is fundamentally different than the way it was being done before. So it's way more granular than it was being done before. So it's taking more time.
First of all, Madam Secretary and your team, thank you for being here. And I know you're digging from a hole that you're digging out of a hole that you didn't create. So we appreciate all of the work on a lot of different fronts. I just had a couple of questions. 2 are follow-ups from last December. One of the questions I think I had raised was around whether the old contractor was ultimately liable for any of the major issues that we had, and you had said that you were gonna see if there was any ability for us to recover any of the funds lost in the fact that they didn't meet any of the deliverables. Is there any follow-up on that from the legal team?
Which contractor?
This was in finding A, this was the previous hospital claims audit contractor.
Can I get back to you and
Sure.
can I take that? Because we have a few contractors, that's why.
I will send you the specific reference.
If you
Yeah.
can, and then I will get back to you on that one.
Great. And then one of the other issues we raised was the vacancy rate within the Medical Care Programs Administration. And I know that was something you said was a top priority, obviously filling a lot of vacancies within the agency, but can you talk a little bit about what the vacancy rate is currently there? Have you all staffed up appropriately as we've figured out the new system going forward?
So I will have to get back to you on that. So the vacancy factor was still high when we last connected. And we've made some leadership changes in our HR and how we go about hiring some of these positions. So staffing is better, but what we also learned, even with staffing, is that training is an issue.
Yeah.
And so now we have a new training position that we are in the process of recruiting. So even though we have filled many of these positions, the training for the positions wasn't adequate.
Okay.
Let me get back to you on the vacancy and how it's changed from the last time I was here, but then the lessons learned from filling those positions, because the turnover of those positions, even when we were filling them, the attrition was just as high. So we were kind of chasing our tails, and not until we identified the training needs were we able to stabilize what we were filling. So I'll have to get back to you on where we are now.
Okay. And then I did have a follow-up question on the DDA piece with the self-directed services. You mentioned that it's been flagged by CMS. Can you elaborate any more on sort of some of the problematic issues that your department's dealing with, or how that's playing out?
So not flagged by CMS, but we are, this is not a state-only program. It's not a state-based program.
Right.
We draw down federal funds in order to run the program, and there are requirements in running a Medicaid waiver, one of which is cost neutrality. So the idea being that the cost of the program will be equal to or less than institutionalization. I can tell you that we have blown through cost neutrality. That's one. In addition, when we started the self-direction under the Self-Direction Act of 2022, we now have services that are available to persons in or participants. I call them patients, and people keep correcting me. Participants in self-directed services that now have access to benefits that people in the traditional side don't have. So what we're seeing is a growth in self-direction that we've never seen before. So when I started in January of last year, there was approximately 2,200 people in self-directed services. We're now at almost 4,000 people. And so that's led to many things. One, increase in budgets related to self-directed services, but also the financial management consulting services groups, some of the complaints that you get about payments related to. The FMCSs, when they were brought on, they were at about 1,500 at the time when those contracts were signed, and the growth was expected between 1,800 and 2,000. Now we're at almost 4,000. So they've had to staff up as well. And so the growth is unexpected growth, and so part of the policies, as well as also to educate around self-directed, because when you're a self-directed participant, you are now the employer of record. So you have to, know how to do time cards and sign time cards and hire staff. So there's just a lot of education and training that's now happening as part of those policies, but things that were not codified previously to provide guidance not only to the participants, but to the support brokers, and quite frankly, even in our own CCSs, our care management teams, we the agency has not done a good job training our own care managers to advise people who self-direct well. So we are shoring up every part of self-directed services.
Okay, and you had said that the attestation issue was something that CMS had raised, so is that, that's, I guess more specifically what?
In our discussions with CMS, they have said most states require more detailed documentation of, most states require more detailed documentation, not just an attestation.
Okay. And I would just echo the comments of Senator Lamb. I mean, I think we're all hearing that, and we're all hearing struggles with the change in the new direction, and just, you know, would urge you all to just continue. I know your team is doing it, but obviously these are, you know, really difficult cases, and families are dealing with situations. And I know I've heard from a number of agencies that things that for the longest time were approved are now suddenly getting denied, and they're sort of going through a totally new process. So just urge you to continue, as you're doing, really working with the community.
Can I just add a comment to that? So, you know, we all have health insurance, right? And from your health insurance, what did you get? 3, 4, 5 choices, maybe? That was your benefit. So just imagine of the 20,000 people, we have about 4,000, almost 4,000 in self-direction. We have almost 17,000 on the traditional side of services. Each benefit design is unique to the individual for those services that they get. And I'm not including the somatic care and the benefits that they get on the Medicaid side. This is just for DDA. So every benefit design is unique to that individual. So it's very, very, very complicated. And I say that because most of the people are actually getting the services that they get, and the number of people that we have in our system that we're tracking that have outstanding issues, either complaints about payments or person-centered plans that are outstanding, is less than 100. So it's small in comparison to the number of individuals. So it's helpful to us when we get concrete examples, or with the participants' permission for you to share their information with us directly, for us to be able to outreach to them to address their particular issue with them directly. But often it's in generalities, dozens or hundreds, and our data does not suggest that that many people's needs are not getting met. So I would ask, of course, with the participants, we can't share information if they don't agree, but it's helpful to us to have more specific information because the benefit is so specific to the participant, to work with them directly to solve their specific issue.
That's helpful to know. Thank you for that. And then the last question I have was actually at the request of the chair of HGO. Can you talk a little bit about the rare and expensive case management program, the denial of services, and what the plans are moving forward on that?
So that's a Medicaid program, and it's based on a set of diagnoses that are written in COMAR. So I'm not sure what the denials that HGO is referring to. And again, it's specific to the diagnosis that are in COMAR. So if there's a specific issue that the HGO is interested in, happy to follow up on that as well.
Okay, yeah.
But that is on the somatic side of the house?
Yeah.
Okay.
Okay, we'll follow up on that, but thank you for your work on the other issues.
Sure.
All right, thank you. It seems like no further questions. We'll let you go so you can go meet with President Ferguson. Thank you so much for being here.
Thank you.
If we can have,
Sorry, I don't understand.
store our lives, but we can have Secretary Scruggs come back in from. And once Secretary Scruggs gets back here, I know Senator Quarterman had a question for her, or questions, and Delegate Arns too. All right. Appreciate everyone's patience and indulgence in kind of the switching of chairs here to be able to accommodate Secretary Harris-Scott. We'll continue with the questions, the remaining questions for the Department of Public Safety and Secretary Scruggs. I think next on the docket is Senator Cornman. Go ahead.
Thank you, Chair, and thank you guys for being here. Just want to follow up on a few things here real quick. You had mentioned earlier about the, I guess just the context here. There's 18,000 inmates, obviously, that are the responsibility and the obligation, as the chair said, of the state to provide health care. And I want to talk more about not only what happens inside those facilities with the contractor, but outside in the community. So what I'm getting to specifically is 3 of the largest state correctional institutions are located in District 2, which is the district that I represent. We understand the concerns with the contractors from YesCare and maybe potentially some of the new issues that have been coming up. But the heart of my question comes down to, you had mentioned earlier past due balances. You talked about earlier about past due balances and identifying past due balances and going after those. And so in our district specifically, it is our responsibility, not the state's responsibility, it's our responsibility as a community, our hospital and our local EMS, to care for these individuals when they're called. And what we have had happen here repeatedly is those past due balances you referenced not being taken care of. You know, the previous contractor who had some bankruptcy issues and other things, there's over $50,000 that's still owed to a EMS company that's in a rural part of our county, a volunteer-based EMS company. And this is not a large corporation. This is not you know, a paid system. It's a volunteer system that has over $50,000 that is still owed to them by this previously, you know, contracted entity. And I know that the Deputy Secretary has been very helpful. We call probably almost every month because we get a call from the EMS company. And I can't imagine part of the contract is call your state senator when you're not getting paid. But that's what's been happening here. And so I guess I have a couple of different questions in regards to that. The first is with the previous contractor. What do we tell these folks, you know, at this EMS company? And I should also mention our local hospital, which we're only a 1-hospital community. The last time I checked with them, they wrote over $800,000 at one point by this contractor. So what do we tell these individuals? And better yet, I guess, how do we get YesCare to handle their previously contracted obligations to these entities to get that money back, first and foremost, that's owed to them? That's the first part. So I think if you had an answer there for that, it'd be appreciated.
Yeah, I think before Joe answers you the yes, I think I do want to share with you, because I think you're referring to Boonesboro and of course Meredith.
Yep.
One of the challenges that we had with YesCare is the lack of a contract, which he can speak to. And
Well, I'm sorry,
the lack of a contract directly with those entities. And one of the things that we have ensured that Centurion does is that they create that contract because it gives the state the ability to do some things that we weren't able to do, that I'll let him get into.
Thank you, Senator. For the record, Mary is my favorite legislative aide of any of y'all's, no offense.
She's mine as well.
Yeah. No, I mean, as the Secretary was saying, look, as far as moving forward, one of the things, and the state is in a kind of a difficult situation in that, based on law, there are provisions within any statewide contract, mandatory provisions related to prompt pay. And in order to be eligible for the prompt pay provisions, you have to be designated as a subcontractor, and that's a defined term within COMAR. And the element of that is that there is some sort of an agreement between the two parties, right? As I'm sure all of y'all know, anytime you're dealing with subcontractors and prime contractors, there's the issue of privity, where a prime, the state contracts with a prime contractor, not with a subcontractor, right? So it really, we can't get in the middle in most instances of that contractual relationship, because by doing that, you then assume all the liability. So that's why there's that privity. Having said that, and as the Secretary said, one thing that the state is able to do in instances related to subcontracting agreements is utilize a prompt pay provision within the contracts, which gives the state multiple different options, such as either withholding funds from the prime contractor until the subcontractor is paid, sometimes paying directly, but really the What hinges on that is whether that agreement exists. Now, what I can tell you related to the YesCare contract and all those invoices going forward that might be in relation to that, the final invoice with YesCare has been held as of this point. A letter went out to the vendor from the state saying, we are not going to pay you until you have paid your subcontractors. And as of now, and we are in regular communication with many of these subcontractors, many of these providers to see what is due, and with YesCare themselves to determine, when is that payment going to happen? Because our position at this juncture is we are not going to pay the vendor until they make good with the vendors that they contracted with.
Okay, so I appreciate that part, so that way we hope we can get that company paid for their previous obligations.
Yep.
Going forward, I guess you alluded to as far as what type of protocols are in place now so we don't have the same situation happen again. Fortunately, to date, we checked with them this morning, Centurion has been up to date as far as paying them within their contractual period. We could always like to see a little better, but they're within their window. But I guess going forward, what tools are in place? You mentioned there's, I guess, a contract here now with that specific entity and the EMS company, so that we hope this issue doesn't arise again. But as you know, it was arising every month for the last many years that I've been in this seat. So if you could elaborate on that, what tools are in place now that we don't have that situation again that's already happened? And again, it's not the detriment of the small EMS company.
Well, so again, I think the best thing, and I know we've had those conversations with Centurion, we've had these conversations with some of the previous subcontractors that have carried over to the new contract, is get a contract, right? Get something in writing, four corners, right? Because that, not only on the state side, but on the subcontractor side, it gives them the ability to take whatever action they find appropriate. Because that's one thing that can't be forgotten is that, if you have a contract anywhere in life, right, you have a remedy to make sure a contract is executed. Now, I'm not saying a small Boonesboro EMS company is going to necessarily hire a lawyer and sue a massive multinational corporation, but for some of these large organizations, that's always a possibility. And if you have a contract, you're on significantly better ground. This is not legal advice, for the record. But at the same time, the best thing that I think we can do in the checks that we have, and one thing we encourage from all of our subcontractors that work within the contract as well as our primes, is making sure that payments are being made in communication. If there's an issue, let us know. And I know you in particular, your office has been fantastic about this. When there is an issue, you reach out to us and we do whatever we can to resolve any issues. But I know it shouldn't be dependent on reaching out to a legislative office. This is something that we should be able to do in direct conjunction with these subcontractors, with these providers.
With going back to the previous contract with the YesCare, and you indicated that that final payment has not been made till all the obligations have been completed. Is there a time frame based on a week committing back that the department is hopeful that will be resolved by? Are we talking 6 months? Are we talking a year? What type of information I give back to them as far as where they could maybe have a reasonable expectation of being reimbursed for services that they provided nearly 6 months ago?
I mean, as of now, it's sort of open-ended as far as the letter itself that was put out. It was pay your bills. But I know we are in regular communication with our previous vendor to that extent to get updates on when those payments have been made. I know they provide us that information because they're aware that they will get paid once they have made their payments.
Right.
So I think there's some sort of a shared incentive from both parties to
I can
get this
appreciate
done.
the pay your bill statement because I think it goes back to the heart of what Doug and Aaron said at the beginning of this conversation about what happens in the real world. In the real world, if you don't pay your bills, you don't get a service. And so we know that won't happen because when they call 911, we will show up. But the feeling has been the state has been taking advantage of our community here for quite some time, and we hope that's not the case going forward. The last thing I just want to say, Mr. Chair, if you could at least look into, and I don't know if we've contacted you directly on this, but it goes into the heart of care, for inmate care, particularly at MCI Hagerstown. The elevator has been out for over 3 months. And so when their call is made to the infirmary, not only does the EMS have to come, they have to have a fire company from another station come as well to help with the transportation to get them down. They have to take them down 3 flights of stairs. That obviously is not a situation we want to have, not even just the short term, but we're talking the long term here now. And so that needs to be corrected to the point we've reached out to the warden multiple times. We've not heard back anything here as the last couple of weeks, but something that definitely needs to be corrected for the overall care that we talked about of the people that are being cared for there.
And I was aware of that. I knew that we were waiting on a part that potentially they thought was outdated. So they were trying to look at another mechanism of fixing that, but I will follow up on that.
Thank you. Thank you, Chair.
All right, thank you, Senator Quarterman. Just to echo his comments, I've also heard from a lot of healthcare providers who are concerned that they have outstanding invoices that have not been paid. So just to kind of follow up on his point. And to your response, though, you had said that these vendors, these subcontractors are, well, YesCare is not going to get paid until these subcontractors get paid, I guess. Is that correct? But what stops the YesCare from just writing off these losses and then the subs not getting paid?
I think.
Because YesCare is out the door, aren't they? Since we now have Centurion.
Yeah, they are out the door. Look, point blank, you're absolutely right. At the same time, that money is appropriated within the contract, and if there were an indication that that were to occur, then the state does retain, and I welcome anybody, and I'm happy to send you a copy as well of what the prompt pay provision explicitly provides as far as the options of what the state has in those instances. Right now, we have money appropriated for a contract to pay a vendor for services provided and all of the additional elements downstream of that, such as paying these additional providers. In the event that that does not occur, or we get to a point where we feel uncomfortable with the prospect of it occurring, then there are mechanisms that the state can do to ensure payment is available. If a vendor goes bankrupt, for example, vendors are also, or these providers or subcontractors are obviously able to go through the bankruptcy proceedings and make claims in that regard as well. But again, I think every individual provider has to make the best decision for their own financial state as far as which avenue to take.
But some of the legal proceedings, if they have to go to court to sue, or if there are prompt pay provisions that they need to pursue, those are reliant on the providers then, right? So the providers then are stuck trying to claim that out of YesCare. YesCare has just washed their hands of it and said, we no longer even have the contract. We've walked out the door. That may not be the greatest level of reassurance there. Would the state be able to sue YesCare for not paying these subs?
So I think the state, one of the avenues within the prompt pay provision is the state can make payments and withhold payments associated with, or what is executed to a prime contractor or allocated to a prime contractor directly to subcontractors or providers. But really the language within COMAR is subcontractor, and that's why I reiterate the necessity of some sort of an agreement being in place, right?
But that's only prospective. That doesn't address these providers who are not getting paid.
No, I don't think that's accurate. It's not just prospective. I think at this juncture, if a vendor has a subcontractor or provider has provided information indicating that they are owed a certain amount of money, and that is not within dispute, because that is an important element within the prompt pay provision, is that it cannot be disputed in good faith, then the state is able to utilize the prompt pay provision, not the subcontractor or the provider.
So at what point is the state going to utilize a prompt pay provision to actually pay these providers who still have outstanding balances?
So there have been instances where that has happened. We have done it for, I think, 1 or 2 vendors at this juncture. There have also been independent audits that have been put forward to ensure, because one of the things that you have to remember, well, you know better than probably anyone as a doctor, that when you're dealing with these Medicaid reimbursements that are going on, there's often a lot of conflict regarding whether what is claimed by a provider is actually what is eligible under Medicaid or is what the service that has actually been provided. So I know within that Medicaid process, it's not often, black and white. Yes, it happened, yes, it didn't. There's certain, my understanding at least, certain levels in discussion and arguments that occur related to that. So again, I think the prompt pay provision does give the state a certain avenue of action that we can take, and we are hopeful at this juncture that this vendor will provide the payment as we believe that they should. And if not, we retain the ability to take appropriate action accordingly.
So I guess 2 points. And one, can you send us the numbers, the full accounting of how many subcontractors or providers have not yet been paid, and how much each one of these subs are owed? And 2, can you give us assurance that at the appropriate point in time that you'll proceed with prompt payment pursuits to ensure that these subs can get paid?
I think this department has every intention of ensuring that subcontractors and providers that have provided services that are in no dispute that those services were provided are recompensed accordingly.
Okay. Would urge that you make sure that you follow up with those prompt payment provisions, at a point where it doesn't look like YesCare is going to be able to provide payment to these providers, because they are basically just on hold right now. And then if you can give us a full accounting, that would be great.
Yeah, one thing I would say also, again, speaking about communication, look, we can do our follow-ups, we can talk to these folks, but the more these providers, these subcontractors reach out directly to us and say, hey, I'm due, that's helpful for us. So we're obviously doing our part, but at the same time, let us know.
Okay. Doug Arns, followed by Senator Hester.
Thank you, Mr. Chair. I go back to business when I get in these hearings. I listen to all the stories about the number of nurses, number of psych people and all that stuff, but I always wonder, how does this happen? I mean, you have a secretary, your comments have been you're changing some things from the previous secretary, and we always seem to go to the secretary, but fundamentally, you still have the people doing the job that they were doing prior to this. And I don't understand how my calls to some departments go totally unanswered, and there's no accountability all along. And I'm certain that the previous secretary didn't say, don't do this, or don't pay attention to this, don't pay attention to that. How do you rectify that? How are you going to fix that? Because it goes deeper than just you, with all due respect to your position. You're probably very effective at what you do, but it's still the deeper down dig you have to do. And we see this in every audit. We went through it, we just went through it in Secretary of Health. We're gonna change something, but the fundamental change is you're the change, and that has to go somewhere else. How are you planning on implementing this to come out of this? I mean, it doesn't make sense to me that any contract could be written the way that this last contract was written. It doesn't make sense to me that there's zero accountability, and I don't know how you as a secretary are gonna do that. Maybe this is fodder for a long conversation, but it's disappointing to continually come in here and listen to these type stories of the failures of my predecessor, and I blame it on my predecessor. Moving forward, in 4 years, 8 years, you may be the fodder of this. And I just would like to see the state come up with a better solution, a better fix, and a way to address these problems so we don't have to come in here and feel like we've done nothing today.
So I agree with you. I think it is a culture change that we have to go through. Also, at my level, it's digging down deeper, and not just at this level, but being involved, which I have been, being more involved at lower levels to make sure they understand the accountability that should take place. What I have seen in the department over my years is there is a lack of accountability at times in areas, and we have to make sure that people understand that accountability doesn't always mean firing someone. It may mean a reinvestment in training because they don't understand what procedures are. So we're going back and we're looking at that areas, and we're making sure that people are in places where they belong and not just in a place because that's the job that was given to them, but that the job that they have is a job that they can actually do. And then after we've trained them, we hold them accountable for that. So it is going to take some time to change that culture, but we are working on that. And I am an integral part of making sure I'm in the institutions. Anybody will tell you, they see me, I'm there, I pop up, I talk to medical, I talk to custody, and I have to be there so they understand the importance at my level.
I wish you luck on that, because in my world, I hear this every audit. I hear we're going to do just similar to what you said. We heard from our educational institutions a couple of weeks ago, and it's stuff that I said every business that has a remote chance of succeeding is doing this every day, and now we're coming with an epiphany that we're going to change something that we should be doing every day. It's going to be difficult because we're really dealing with the people beneath you, and you didn't go through a complete and got rid of all your staff to come up with new staff. And I don't know how you address that other than if you can do what you said you do, God bless you. Thank you.
Thank you.
Yes, thank you very much. A couple hours ago, we were talking about the university system and the hospitals that we have in the state, and you mentioned that there were a number of reports and feedback that you had received prior to taking this job. Are those available, and could the committee have access to those, please?
We have a binder full, and happy to share them with you.
Thank you so much.
I just had a couple of last follow-up questions, and then I think we're finished. And again, appreciate your flexibility in staying so long. I wanted to just go back to the staffing, the point that Delegate Moon made with the new contractor. So they've been in place since August, and you were talking about, obviously, they've been cleaning house and moving things around, but that's August, September, October, November. We're in the 6th month of the contract already. Do you have data that shows that in those 6 months or so, 5 months or so, that they've been meeting the staffing needs?
They're still working on those recruitments, as was mentioned earlier, for example, we mentioned earlier, today and tomorrow, there's a big hiring event that Centurion is doing in Columbia, one of the hotels out there. So they have been moving along steadily to increase their staffing. But as other folks have mentioned earlier, some nurses would rather work in a hospital than come work in a prison.
Right,
So
but-
they
but-
have to continue to build up that staffing under this new contract.
So what's the gap that we have right now? If I were to ask you for a staffing report today for the last 5 months and going forward, what's the gap? And when do you plan to have a report from Centurion that says we are as close to, obviously you're never gonna get it perfect because there's gonna be ebbs and flows, and if 10 people quit tomorrow, obviously that's gonna be a gap that you can't fill overnight, but when are we going to get from Centurion that we are as close to fully staffed on the contract and the terms of the contract as we can be?
Well, they are, as I said, working diligently. Right now, the last figure that I saw was 53% overall, but that's across the entire spectrum. So
when do we expect, I mean, so after 6 months, they're only halfway full? That's.
People come, people go, people have been let go. So.
Wait, I see.
3 months.
I thought the contract went into effect August 1st.
August or September.
It was August.
August 1. August 1.
August, September, October, November. So we're in the 5th month, December. So they've had 4 months already. And we're only at 50%?
That was the last figure that I saw, but.
When
is
was
it
that figure
bi-weekly or
from?
weekly that they? It's weekly. So each Friday, there's an update. So that was the last figure I saw.
When is their plan to be fully staffed?
Well, their plan is to do it as quickly as possible. That's why they have all these recruitments from the Eastern Shore to Western Maryland to
Okay,
get it
but
filled as
what-
quickly as they can.
At what point, I mean, 50% is pretty terrible. So
Yeah.
at what point do you go back to them and say, hey, you've had 8 months and
So
you're
if-
still at 60%?
Well, I've, not only have we said that, I think I've made it perfectly clear that liquidated damages are going to be assessed for you not
So,
reaching your
all right,
quota.
so when do liquidated damages begin to be, what is written in the contract that says we expect you to be at 70 or 80% within 6 months? Is there a provision in the contract that says that? Or is this just a back and forth negotiation?
If I may, the staffing liquidated damages are assessed monthly. Once the assessment is done by the internal audit team that I have, it is then sent to the provider, and they have 15 days to respond. Then when it comes back to us, that audit team reviews that response to see if there was a discrepancy, or then the notice will go out that we still confer with the original audit finding and the liquidated damages are held. So that is already happening every month, those liquidated damages. As far as them getting to a higher percentage of staffing, I think all of us in this room are aware of the challenges with hiring individuals, especially in the medical field. And as was said prior, when we were here, that what's enticing to make you come want to work in a prison? Many people don't want to. So that's why they're having these robust recruitments. We've had several robust recruitments in order to try to recruit individuals to come in. So they are experiencing, just like we do, challenges to get that. But we will continue to hold them accountable with liquidated damages until they get to that point.
I will just say, because I think we're just gonna continue to go round and round on this. I think if OLA were back up here, they would say we told you so based on the previous 3 audits that said that staffing was a problem. And I guess, I mean, the other major question here is if we only are at 50%, how are we providing care? If we're only at 50%, how are we possibly providing adequate care for people in the system right now?
Because again, we are able to identify our incarcerated individuals that need chronic care and have certain needs.
But there has to be some shortfall.
And we are able to do transfers to place them in facilities where clinics are that support their day-to-day need. We are able to do that.
Then being 50% short of staff, see, I could not do the same amount of work in my office if I had half the number of staff that I do today. So I think we really need a report from you all, and OLA needs a report from you all, like bi-monthly, and I think many of us will probably have this conversation when we come into session for the JCR, because a 50% staffing percentage is not acceptable, and I think we need to very clearly see when are we going to get from Centurion a level that is appropriate, what you need, as, like, what's the bare minimum percentage that you need to provide appropriate care? Is it 80%? Is it 85%? And when we're gonna start seeing liquidated damages? And frankly, I would love to know from your office, Madam Secretary, what is the audit team's criteria now to start assessing liquidated damages? Again, when do we start penalizing for Centurion for only having half the job done? I didn't mean for us to go down another rabbit hole here, but I didn't expect that number to be quite as low as it was. So I think that's all I have. I don't know if there's any other members of the committee who had any more questions.
Yeah, I think if I'm recalling correctly from the audit identified that YesCare, the prior vendor, had an 81% overall staffing rate. So right now, we're even well below that in the new vendor that we have and just entered into an agreement with, which is really, really concerning. This is really, I think is a callous way of denying people health care. These are people that are under the care of the state. It's not acceptable to have that happen and continue to happen. And so, my question on this contract is it also a fixed fee contract, the same type of contract that we had previously that seemingly fell short with YesCare?
It is a fixed fee contract, but there are avenues for renegotiation depending on the ADP level and change. I know one of the things you mentioned earlier is dependent on the number of population. Does pricing change? If the ADP changes within a 10% ratio, then that opens up renegotiation regarding the pricing associated with that. And I think it's probably a much larger conversation, but discussing the differences between a capitative model or a fee-for-service model versus a fixed fee model, I think it's fair to say that all exhibit different pros and cons. And I think we'd be happy to have that conversation with you.
Okay. I think it is pretty striking that I think our auditors said this fixed fee model was something that really should have generated a lot of caution. I guess what you're describing now is maybe a few more guardrails in place to address this. Obviously, we can tell from the staffing numbers, it still looks like it's falling short, and hopefully that will be resolved soon. But, I think we are very wary of the fact that while this audit was going on and nearing the end, and this audit report was coming out, the state re-entered into a fixed fee contract while the prior fixed fee contract didn't seem to pass muster. Okay, any other questions from members of the committee? All right. Well, thank you for the time. We appreciate it. We'll have Mr. Tannen and his team come back up before us. And as your team comes back up, if you can address, I think Senator Hester's question about surplus. I just want to be clear. My understanding is that there is
no surplus.
That is not a surplus.
There is no surplus.
That is not a surplus.
No
that
surplus.
Is 1.2 billion that they basically recovered of the 1.4 billion that they potentially were on the hook for, right?
No surplus. I actually had a sidebar conversation with them. Just a few things. We look at the closeout entries every single year, and you will get a report in January with our assessment of the 2024 closeout transactions. I can't disclose the contents of that report now. It hasn't gone through a quality assurance process, but I can tell you what was just shared out in the hallway, which I believe is accurate. If you took all their positive numbers and negative numbers at the end of the year, they are $500 million, about 500 million in the red, which is normal. Again, for her to come out and say that there's a surplus, it doesn't make sense because we recover based on the expenses that we incurred. And so if we had a $1 billion surplus, it would belong to the federal government. It wouldn't be our money. So they have an account with a positive fund balance. If you go back to our audit report, you'll see we had a lot of positives and negatives. The problem was they had no way to identify to what extent one positive number had anything to do with the negative number. And so as part of the new process, hopefully that they're putting in place, they're going to be able to go and identify and correlate those numbers. So that slide spoke to one balance in a list of a lot of balances that has a positive. If the department would have put up all those balances, you would have seen many, many negative balances. So that picture, I don't want anyone to walk away and confirmed outside in the hallway, there is no surplus funds. So that is not the case. And in January, you will be getting a report from us to say what support we were able to see for the year-end transactions. Again, our most recent years, we look at some major agencies instead of the little small ones. They are one of them, and our conclusions will be issued to you in January. I feel comfortable saying that we're not going to tell you that there's a surplus, but more than that, I can't disclose now. And again, it's a work in process, but we look at the balances, and we're doing the work, sometime in the past couple of months, looking at what support they had for the entries that they booked back in July and the subsequent activity to see whether or not those funds were ultimately recovered if they booked a receivable. And so those conclusions will be shared in our January closeout report to the committee.
So is it fair to characterize this as before, the October 2023 audit showed potentially up to a $1.4 billion loss? It's just that they've recovered $1.2 billion of that?
I don't know where their numbers are coming from. I can tell you that we identified in the past that in totality, the net number that they were booking as a receivable, which I don't think you should net those numbers because they are completely disparate types of revenue sources and expenditures, and they may have no correlation. So we may have overdrawn on one thing and underdrawn on another. So I don't advocate doing that, but and you do have to look at it, and the approach that they're taking is looking at it line item by line item is the approach that they need to take to resolve this going forward. But to put up a slide and show that a clearing account, because they have multiple clearing accounts, and if you were to ask them, is there another clearing account with a negative balance, you may hear that there's another clearing account with a negative 900 million. And so that's what I'm saying. That slide pointed to one account with a positive balance. It is not a surplus. Confirmed with them out in the hall. They apologized for using the wrong term and said I could share that information with you when it came back to the table.
All right, thank you. Senator Hester?
Just if the Department of Health is still listening, it seems like that report, that one slide was slightly misleading. And if they want to revise the report and send it back in, that could be helpful.
More than happy to share that with them. We do speak to them. Actually, we just met with their team yesterday just to introduce some of the new players. I don't mind. We have an ongoing dialogue with them. I could get them to resubmit the slide to clarify. It may be beneficial, again, if you want something immediately, for them to give you a list of what all the balances were in all those accounts at year end, and you'll have a better picture. If you'd like that, I could ask them to get that to the committee.
Yes, if you could ask them to get the year-end balances for all those clearing accounts, that'd be great, or work with our committee staff to do that. Thank you.
All righty, I know the hour is getting late. There are a few things that I take personally, one of which is when an agency says that what we include in our report is factually inaccurate, and I don't feel comfortable walking away from the table without that being addressed. I go to sleep at night never worrying. We had $1 billion finding in this report. I was never worried about coming to this table and talking about it, and I don't look at a single work paper. I am 100% comfortable with all the facts, and I can tell you that it's not a vacuum. We just don't go look at something and then issue a report. We've had ongoing meetings with them, and up to the time that we are sitting here today, they have not given us any documentation that goes and disputes the factual accuracy of any of the findings in that report. And, I'll just stand by our comments. I'll stand by our auditor comments that we put in the report. And I think the subsequent activity, as they were questioning the concept of a contingency plan, I think to speak to Delegate Solomon, that was what it was for. Because today, 6 months later, we're still only getting 50% of the healthcare staffing that we need. A contingency plan would be, if the contract doesn't work, do we have another contract in place to get that staffing from a different source to make sure our inmates get that care? That's what a contingency plan would be, and I just wanted to go with that on record. We have 3 other things to present today. I'll move quickly since the hour is late. The first one is a presentation that you have before you on our Special Investigation Unit. That term should sound new to you because in past presentations, it was called the Fraud Investigation Unit, which the committee has graciously supported. We changed the name in this past year to better reflect the activities of the committee. I think putting it in there and calling it a fraud investigation unit would imply that anything that that unit does has some fraud implications. And many times it has an ethics issue, which is not fraud related, or it results in internal control deficiencies at that agency. To go and better take away that stigma from any time we mention the unit in our reports, we've changed that name. Page 6 of the handout, if you want to look at it, the only thing I would highlight is it continues to be a robust form of information and a source for outside parties to submit concerns to us. And we consider each and every one of them. And page 6 gives a breakdown. We're on target to have about 1,300 referrals for the year. It's all over the place as far as what they are. I think it's an incredible value to the state, and we continue to anticipate that it's going to grow. The findings that we have are not just special reviews. It gets incorporated into each and every one of our audits. They're a resource to our ongoing audit teams to provide some fraud perspective and mindsets when we're looking at some of the contracts, and they were integral in some of the different reports that we've presented to the committee. That's all I have for that presentation, unless you have any other questions. I could walk you through the slides. Yep, that works. Moving on, see you later. Next one is our follow-up process and repeat audit findings. I'll ask Chris Tamanis to come up to the table, and The only introduction I will give is that the presentation this time has changed from our past presentations due to the cybersecurity law, which prevents us from disclosing cybersecurity findings and disclosing whether or not certain findings were repeats. As a result, when we started looking at discussing the follow-up process, someone who, with an inquisitive mind, could have figured out which agencies didn't clear their cyber findings, and as a result, we have to kind of change the format of our presentation. And with that, I'll turn it over to Chris to quickly walk through the presentation.
Thank you, Brian. Thank you, Senator Lamb, Delegate Solomon, and committee members. To keep it brief, page 2 of the presentation includes our overview. We look at an overall audit cycle, which is generally 3 to 4 years. We look at every audit we do. One highlight as of June 30th, 2024, is that our repeat finding percentage has started to creep up again. It's about 30%. We have an exhibit in the back to show you the range, so it's starting to creep up again. We have 2 follow-up processes in place, as discussed on page 3. And page 4 presents the current results for the first process, which is agencies with 5 or more repeats. We had 6 audits that were subject to quarterly status reports. All of them are still ongoing, pending the status report process and the next audit. So we don't have firm data to report to you on that. The next slide presents background on the JCR follow-up process. That process withholds funding from agencies with 4 or more repeats. We have recent results on page 6. The April 2023 JCR contained restrictions for 4 agencies that hadn't fully resolved their findings, and we have about 80% collective findings that were still in progress, so the budget committees did not release the restricted funds. We're looking at the April 2024 JCR right now, and we'll have status reports for those 5 agencies during the 2025 session. Just to summarize, on page 7, we feel these follow-up processes provide useful tools to compel state agencies to generally take meaningful corrective actions. We believe that vacancy rates at the agencies may be contributing to the number of repeats, and we're starting to present those rates in our audit reports. And we're going to continue to monitor the trend and keep the committee up to date. Any questions?
Okay.
There we go. I just wanted to say thank you all, and I know that we had some conversations about potentially making some tweaks to this to make your lives a little bit easier, our lives as the committee to stay on top of this, and so I think we're excited to see some recommendations on paper that we can all consider. Just want to say thank you for that.
If no other questions, I'll move on to the last presentation, and that is on the summary of reports issued and recommended action. Since September 1st, 2024, we've had 14 reports issued, 3 recommended actions. I'm proud to say that we just wrapped up the second recommended action, which leaves just one, and that is, a letter of concern recommendation for the Maryland Public Broadcasting Commission. It should be familiar to this committee because this is a follow-up to their failure to demonstrate that they responded to your last letter of recommendation. It's a source of incredible frustration. It's very much like UMGC. They have an affiliated foundation, and their affiliated foundation is actually run by their staff. We had some serious concerns with the monitoring and oversight of the activities, including some diversion of what we believe were state funds to the foundation. We were continuously told that it's foundation activity and we can't look at it. I think there is some gray area in between where we should be able to identify what monitoring efforts that they have to go and ensure that the activities of an entity that is working on their behalf is working in the best interest of the state. We have put some suggested language in there for that recommended action, but we may need to consider bringing them at a future JAC if they don't address it. But it's, again, if you look in the last report on page 21, page 21 of the last report has the last committee's letter of concern. I'm looking at the Maryland Public Broadcasting Commission. I apologize if it wasn't in your binder, but you have a copy of your last report, and then our audit report contains findings associated with our inability to go and demonstrate that they had addressed the concerns that the committee had raised. It continues to be an area of disagreement, and so I think a letter of concern is warranted.
All right, thank you. Any objections to a letter of concern from the committee or from OLA, I guess?
No.
Oh, from the committee, okay.
One last thing, I would be remiss, it's coming on 6 months in my new position, so I did want to thank the entire committee and the co-chairs for their ongoing support of our office, and Vicki Gruber's in the back. She is continuously cheerleading on our behalf, so greatly appreciated, and looking forward to another great year next year with shorter meetings. Hey, we could dream.
Yes, I think we've heard some feedback of maybe shorter but more frequent meetings.
Yeah.
All right, thank you to you and your team. We really appreciate it. Thank you to the members of the committee. Seeing do you have anything?
No, just thank you to you and your team. I think this fall we've continued to just uncover more and more things that are problematic, and we wouldn't be able to do that without you all. So thank you.
And happy holidays to everyone.
Same.
Yes, sir.
Thank you. We're adjourned.